Oh, you want my to go for your we had to go back to that one down there.
Okay, can everyone hear me? Great. I think we're going to get another minute or so to get everyone here, get everyone seated. There's plenty of room up front. We also have some wheelchair accessibility up here up front. If you'd like to come here.
Don't take out our equipment, okay?
Okay, great.
Don't take out our equipment.
Welcome to the ALS Association Golden West Chapter's Ask the Experts, Living with ALS. My name is Giovanna D'Angelo, and I am the Director of Special Events for the ALS Association Golden West Chapter. We have a great program for you today, discussing important aspects in clinical care and promising developments and research that we know you will find very informative. I want to thank you all for coming today. We are so fortunate to be able to present this educational symposium to the ALS community here in the Central Valley. In addition to those of us who are here in the auditorium, we also have many people who are participating through our live webcast. Please take a moment to say hello to all the people who are watching today via email. Let's wait. I guess we can wait on it. Great. Okay. Today's event would not have been possible without the support of our sponsors. I would like to thank UCSF Fresno for providing us such a wonderful venue to host this event. I would also like to thank the vendors who are here today, Hillron and Synapse Biomedical Inc., for sponsoring this event as well. Please make sure you stop by their booth in the reception area. In addition, I would like to take the opportunity to thank the tireless efforts of the team here at UCSF Fresno, especially Virginia Consley, I hope I pronounced that right, and Leland Vanderpool, without which none of this would have been possible. Finally, please allow me to introduce the dedicated staff of the Golden West Chapter, each who have worked tirelessly every day toward our vision for a world without ALS. Fred Fisher, who's our president and CEO of the chapter, he will be here later. You'll be meeting him during the research presentation. Also here today is Cheryl Goldstein, our director of development. She will also be joining us during the research section. We have Madeline Thompson, our director of care services. Madeline, you in here? Right here. Oh, there she is. She's on. Okay. We also have other members of our care services team. We have Margie Petrenkis, our care manager of Central Valley. We have Caroline Zettner, our ACC Lung Library manager. She's in the back there. And finally, we have Jenica Lancy, our director of marketing and communication. Jenica does an amazing job with all our PR and marketing at the chapter. So thanks, Jenica. The program format for this afternoon will be as follows. Our first speaker will be Dr. Rosenfeld, who will make a 20-minute presentation with a 10-minute Q&A, followed by, also please note that we will allow some time for questions from our internet viewers, and then it's going to be followed by a panel of experts from the Neurology Associates Central California Neuroscience Institute, that's a mouthful, who each will give a 15-minute presentation. At the end of their presentation, the entire panel will be seated up here for an additional 10-minute Q&A, and Dr. Rosenfeld, I believe, will be joining them as well. There will be a break at 4:05 p.m. to 4:25 p.m. for you to have some light refreshments and to visit the vendor exhibits. The program will reconvene at 4:30 p.m. for the second session, which is research development. So let me begin with our first presenter. Our first presenter is Dr. Jeffrey Rosenfeld. Dr. Rosenfeld is a professor of neurology at UCSF and chief of neurology at UCSF Fresno, as well as director of the Central California Neuroscience Institute. Dr. Rosenfeld has over 18 years of experience in treating patients with ALS and related motor neuron diseases, and has conducted numerous clinical trials and basic research over these years. He was recruited to the Central Valley in 2007 to create a resource for patients with neuromuscular disease, including ALS, and has since built a large and comprehensive multidisciplinary treatment team here in Fresno. In addition to the ALS treatment program, Dr. Rosenfeld has organized a subspecialty neurology division in this area where none existed previously. Dr. Rosenfeld earned a PhD at the University of Connecticut and worked as a postdoctoral fellow and faculty at Johns Hopkins Medical Center after that. He attended the University of Maryland Medical School in Philadelphia and completed a residency at the University of Pennsylvania in Philadelphia. Dr. Rosenfeld joined the faculty at Emory University in Atlanta before moving to Charlotte, North Carolina to establish one of the largest multidisciplinary clinics in the country. Without further ado, Dr. Rosenfeld.
Thank you very much, Giovanna. It's my pleasure to welcome all of you here and those of you who are viewing in on the internet. For those of you not from Fresno, or if this is your first visit to Fresno, welcome. Hopefully we'll see you again. And it's really a pleasure to be able to have the opportunity to talk directly to you. As Giovanna said, I've been treating ALS patients over 18 years, almost 19 years. This is an incredible time in the field of ALS and motor neuron disease. It's incredible because, putting myself in the patient's perspective, there's an explosion of information. But along with that massive amount of information, I think there's equal parts confusion. Because for all of us, the scientists, the clinician scientists, and you, are trying to make sense of this. So what I'm hoping to do today is focus on only three things that will be a segue to talking about sorting through some of that explosion of information. First of all, we're going to talk about how variable this disease is. It's like preaching to the converted, because I'm sure you've already noticed that. You all don't have the same type of symptoms. When you come to clinics, your colleagues in the clinic are very variable. And likewise, the way we call patients that have a motor neuron disease is also very variable. And that's a problem, which I'll describe in a moment. And so all taken together with the confusion and the explosion of information, the excitement, you have to ask yourself, are these hopeful times or helpless times? And I put helpless times in small just to emphasize where I want you to go. These are hopeful times. And I can tell you that today and yesterday, alongside this meeting, we've had a scientific conference which is ongoing in the adjacent room, and there have been some incredible discussions about ways to make things better in the field, ways to collaborate together throughout California, and it's just heightened the awareness of how much talent, both in basic science and in clinical medicine, we have right here in our state, just by the migration of different folks for different reasons coming to this state. So, if I lose you along the way, there are three things I want you to remember from this talk. The first is that ALS and the other related motor neuron diseases are treatable diseases. So when somebody says there's no treatment for what you have, you're wrong. The second thing is the diagnostic label, how we call what you have. Oftentimes, if it's not delivered in the correct way, can become the disability, and that's very unfortunate. I want you to be aware of that what you call the label of what you have should never become the problem that you have. The labels we have are very inaccurate, they're very vague. We need to change that. And the third, maybe most important thing I want to leave you with, is that being afraid and fearful of what will come next is likely the worst disability you could have. And fortunately, it's highly treatable. It's treatable by being aware of how hopeful you should be for the symptomatic improvements for the current research that's in the pipeline. Fear should be avoided. So currently, the available treatment options we have are very significant. You may not know this, but when somebody says there's nothing we can do with a person who has motor neuron disease, they're not very informed. And I'm going to show you just a few examples of the many that we have. And following my talk, each of my members of my team is going to present briefly, as Giovanna said, and show you some of the toys and the tricks that we use to give you just a glimpse of some of the interventions that we do to make major differences. But the point is, the differences that you can make simply by doing what we already know how to do very significantly can change life expectancy, it can change the quality and the duration of life for patients that have motor neuron disease. Even more so than the magnitude we were looking for in drugs that we didn't find. Early proactive treatment is the key. Treating patients early and aggressively is much, much better than treating patients after the fact when the symptoms have evolved. And like I've been saying, a clinical variability, how we label you, how we call the diagnosis, that's very important. And we need to work on that a little bit more as a field. So let me start very simply because the time is short. Most of you already know this. But motor neuron disease is characterized by degeneration of motor neurons. And motor neurons normally live in the brain and in the spine. And the diagnosis of ALS means that the motor nerve cells in both the brain and the spine are affected. Because if it was one or the other, it would be a different diagnosis. A motor neuron disease, but not ALS-type motor neuron disease. And sometimes, in fact often, patients will come to our clinics where we will not see signs of upper or lower motor neuron disease, only the other, and they'll have been labeled ALS. And they're petrified. In fact, they should have been labeled as a variant, or they should have been labeled by one of the other diagnostic categories that we have for patients that have some degeneration, but not others. The kind of problems that you have when the upper motor neuron is affected versus the lower are very different. And in the clinic, we know what to look for to determine which cells in the nervous system are affected. So we have this spectrum of diseases that's affected by the upper motor neuron loss, meaning in the brain, and the spectrum of diseases affected by lower motor neuron loss, and where they intersect in the middle of that diagram is what we call ALS. However, the devil is in the details. Within this space right in here, there is a tremendous, tremendous variability. And I contend, from experience from watching patients, that all of the diseases that we actually call ALS are probably not the same thing. I think we need to do better at splitting up the pie right in the intersection here for the different subtypes of ALS. And there is active research, including research going on right here at UCSF Fresno, to better label patients with different subset variations. Now, if you get this diagnosis, you look on the internet, this is commonly what you see. If not this exact picture, some estimate of how long you're going to live. You're not going to see it in my clinic. I'm only showing it to you to show you an example of what not to read. How could they know how long you're going to live? How do they know what your attitude is? How do they know who's taking care of you? How do they know what subtype of ALS? This is a statistical average of many patients, and oftentimes it's wrong. In fact, when research has shown how patients actually fare in the disease, This is a tremendous variability of survival, each line showing a different course. Each line is a different patient, and it shows that patient's course. Some patients actually have very slow, minimal progression over time, others very quick. Is the patient with a very rapid progression, patient with a very rapid progression as in the green line, is it the same disease as the blue line? Maybe not. Maybe rapid progressive motor neuron disease is a different entity. So this is one of the questions that we wrestle with. Is this a complex, multifactorial disease? That is, it's all ALS. It's just like, some people have mild blood pressure and some people have very severe blood pressure. Is that what it is? Or are these separate diseases? I've shared with you my bias that they're separate diseases, but there's a very active controversy in this. Now, historically in medicine, most diseases that were discovered, the first thing that physicians do when a new disease comes about is they go to the microscope. We've done this for all diseases. They go to the microscope after the fact and say, what happened? Like detectives. And if you go to the microscope in patients that have motor neuron disease, it's very straightforward. You think they all have the same thing, because this slide shows dead or dying motor neurons. This is a dead or dying pointer. Okay. Imagine that I'm pointing to those cells up there. They're dead or dying. And that's common in most all patients, or all patients that have motor neuron disease by definition. And if you go a little bit further, there's actually specific inclusions, meaning accumulations of protein that shouldn't be there in these cells. So from a pathologist's point of view, looking in the microscope, if you define the disease by what you see after the fact, you think it's all the same. Knowing what the patient went through in life, though, you think, how can it be the same? How can it be the same that patients that have very mild bulbar speech swallowing problems and severe extremity problems, how could they have the same disease as somebody who's got everything, speech, swallowing, bulbar, extremity involvement, or likewise just bulbar involvement and their extremities? I've taken care of patients, or we've taken care of patients that had to go on a ventilator because of their respiratory compromise, but they were able to walk and carry their own ventilator. And other patients, of course, are not able to do that. It's very hard for me to understand how those could be the same disease. Now, I'm condensing many years of research in the interest of time, but the general idea right now in the field is that cells are happy functioning cells, and then something happens that causes them to start a degenerative cascade resulting in cell death. And there have been many theories, the one I'm about to show you is pretty dated, but there have been many theories that maybe there's a different pathological process that triggers one aspect of the cascade versus the other aspect of the cascade, but the end result is the same. They all result in cell death at the end. In that case, you could say, well, this should be easy. If you could just arrest the cascade along the way, you'd stop the cell death, and the person's disease would stop. But that hasn't worked. And surprisingly, the next thing, if I was just having this conversation, you'd say, well, what do you want to do next? Most of you probably would say, why don't you give more than one drug at one time? So you can arrest the cascade at different parts and stop the cascade. Well, it may shock you to know that that's a surprisingly hard concept for the scientific community to grasp, because putting multiple drugs together that don't work, hoping that they work together, is very intellectually not satisfying. And we do that in medicine, like in chemotherapy, but each individual component of the chemotherapy works separately. So where we have been stalled in motor neuron disease research is finding key drugs that work okay, maybe not enough, and combining them with other drugs that work okay but not enough, and hope that we see synergy. So there are many different variations of this disease, and this time through this talk, again, doesn't allow me to do full justice to this, but suffice it to say that some patients have predominantly upper motor neuron disease, brain, and those folks get spasticity, rigidity, abnormal reflexes. Other folks have lower motor neuron predominant disease. Some have just the arms affected, some have just the legs affected, some progress rapidly, some progress slowly. And it makes a difference. Survival is definitely affected by how you present. shouldn't be a surprise that those who have presentations that mostly affect breathing, swallowing, speaking, they have a harder time over a long course of a disease than those who don't. So bulbar involvement. Now, add to this is where the explosion of information comes. There's been an incredible explosion of information about the genetics behind motor neuron disease. What I mean by that is lots of investigators, many of them in the adjacent room, have identified genes that seem to be associated with patients that have motor neuron disease. And every single time we find one of these, we think, we got it, right? We got this. Well, we've been saying that for so long now that we stopped saying that. That is, we think we have genes that are associated with the disease, but not necessarily causing the disease. There have been so many genes that have been associated with the disease that this paper, this very interesting paper, was published in 2012. Each circle represents the identification of one of those genes. And the size of the circle is an implication of how much excitement or other research was generated from that discovery. In other words, bigger circle, that was really thought. For example, in the lower right-hand corner, my pretend pointer will show you, the SOD gene, which is what we found in patients that have inherited forms of motor neuron disease. When that came out, it was thought to be the potential cause of inherited motor neuron disease. Since then, we realize it's not the cause of inherited. Most recently, there's been a disease right in the middle, underneath the zero number on the timeline, called C9orf. That happens to be the topic of discussion in the adjacent room at this moment. But C9orf was just discovered 2 years ago, and it seems to be a curious tie between patients that have cognitive problems with their motor neuron disease and those that do not. And the presence of C9 gene abnormalities in the population of patients with motor neuron disease is a very active area of current discussion. Because if we can understand what happened in the mutation, the thought is we would understand what happens in the disease. And that's why there's excitement whenever you hear about a new gene. Because of this, we think if you identify the mutation, we associate the mutation with the disease, we discover what the mutation's function is, and we understand why the disease occurred. If only it was this simple, we would have solved this disease 6 times over already. The problem is, not everybody has every mutation, and it's not so easy to figure out what the role of that mutation is normally, let alone in the disease state. So this is my family many years ago, and it's sometimes this is how it feels. Like the weight of the world is on your head. You have all this information you try to hold up and to balance. How are you going to move ahead with new treatment strategies? Lots of clinical trials have come out of this kind of investigation. This is a cartoon showing some of our favorite failures. Okay? These are trials that were well designed, well targeted, and I've shown a cartoon here of the cells in the nervous system, just showing you how many different places in the anatomy of the nervous system we've tried to target to arrest the development of motor neuron disease. Not successfully. Some more successful than others, but none of these trials was a home run. Why wasn't it a home run? Well, there's a lot of discussion about that. Did we deliver the drug incorrectly? Did we not give it high enough dose? Did we not have the trial go on long enough? Or, as this article suggests, and I've been teaching since we started, maybe we were testing apples and oranges at the same time, and it only affected some of the apples and none of the oranges, and statistically, the benefit washed out. So that's the reason why my own personal bias is disease heterogeneity, understanding better the disease heterogeneity, meaning how variable it is from one person to the other. That's why it's so critical. Because in future times, if we could do a clinical trial and keep track of patients in different types of presentation, not saying they all have the same thing, maybe it would help. It strikes me when you go to the home improvement stores like Lowe's and Home Depot, and you go to buy fertilizer, as I have, for your trees. Well, you can't just buy fertilizer for trees. You have to buy fertilizer for citrus trees, for evergreen trees, for the other kind of trees, right? We're better off treating the trees than we are treating the patients, because if we just call them trees, there'd be one kind of fertilizer, right? They're not all trees. So the questions we have is the clinical variability. We need to stratify, means keep track of the individual subtypes of the disease. We need to understand whether patients that have very different biological processes giving rise to the different expressions of the disease, is it caused by something different? And there is a lot of active research directly into this. So I want to just give you two very brief examples, because I only have about 10 more minutes. This is an old study, you can see 1999, which showed what happens when patients use BiPAP. BiPAP is a device that you wear at night often, or sometimes during the day. The mask delivers you some air under pressure, keeps your lungs inflated, keeps you breathing. Those patients in this study, and I forgot the duration of this study, it's been a while, but it was several months. They used the BiPAP machine for at least 4 hours a day. They survived over a year longer than the counterparts in the study that used the BiPAP machine less. Now, BiPAP is a very simple intervention. You're going to hear more about it a little later, I think, but it's very simple. Most clinics know about it. I can tell you that if any one of those drugs that I showed you a moment ago, any one of our favorite failures, if it would have extended life by 12 months, it would have been a home run for the time. But a BiPAP machine alone can extend life by over 14 months. It's a very well-kept secret. Now add to that a separate intervention. How about a PEG tube? Maintaining your nutrition. A PEG tube can markedly affect the duration and the quality of life. And so if you extrapolate together, what would happen if you looked at both PEG and BiPAP, and this is not real data, I made this up. You can imagine if you introduce a PEG tube for getting nutrition early in the course, and you start BiPAP early in the course, you're going to have the best effect on survival. And likewise, if you do both late, you'll have a less effect on survival. And then in between, you can imagine it's kind of a middle effect on survival. But it's not that simple, because I've told you there's biological variability. So if you can imagine then some people have mostly bulbar involvement, speech, swallowing, breathing, and others have limb involvement. If you have limb involvement and you start both early, you're going to get even a better effect. And likewise, bulbar involvement, start birth early, you're going to get better effect than not. So there's a lot of variables at play when we evaluate patients in the clinic. But the bottom line is that BiPAP can extend life, nutrition is critical, a PEG tube can enhance your survival by at least 50%. Bet you nobody ever told you that. And devices that you'll hear about in a moment from our physical therapy interventions can definitely enhance mobility and prevent falls. I call this the paradox of the diagnosis, because if I project myself sitting where you are, having had to deal with the disease or currently dealing with the disease, and somebody tells you or you read on the internet that there's no cure for what you have, and then someone like me comes along and says, but there are powerful treatments for what you have, okay? You have the perception of a critical illness, and you have the reality that you live with, that things change over time. And those two things together equal what I think to be the worst of all the disabilities you could have, which is intractable fear. And of all the things that we see, that my team sees in the clinic, the one thing that's the most common, and again, I think the worst disability, is the fear that comes from thinking nothing can be done, when in fact it's wrong. The alternative is perception of a serious disease, you have the disability, and you get multiple interventions. That's called aggressive treatment. And that's a proactive, more healthy way to think about getting your head in the right place. So just to wrap up and leave you time for a few questions, this is a treatable disease. It's not a curable disease, not yet, but it is a treatable disease. The diagnostic label is very important. If it doesn't fit, don't wear it. If you're told you have some variation of ALS, a motor neuron disease, I tell my patients, those of you in the room that have come to see me, you may remember, I say, don't say I have ALS if you don't have ALS. Say I have a motor neuron disease. And unless you're socializing with neurologists, they're not going to know what you mean, and they won't ask you any other questions. If you say you have ALS, somebody knows somebody who's had ALS. It's been in the literature, it's been in television, it's been on the internet. And then you have to deal with the consequences that might not even be appropriate for you. Eventually, in time, the field will come around. I'm much more encouraged after this meeting yesterday and today, that the field in California will come around faster because we're already talking about disease stratification that we were not last week. And remember, fear is the most severe disability that is avoidable. It's unnecessary. So I'd like to stop there because what will happen now, I'm going to take just a few questions right now, and then I'm going to turn this over to individual members of my team. We're each going to present briefly, as Giovanna said, and then there'll be a panel discussion. I'm going to be back and forth between the adjacent room and here, so if a question comes up and I'm not in the room, I'm coming back. So we'll start there. But are there any questions right now? Yes, sir.
What steroids do the ALS to the muscles?
The question is, what do steroids do for ALS? There really is no basis that steroids, let me say, there's nothing as far as we know. Steroids work because they're anti-inflammatory. They're immune-modulating drugs that are anti-inflammatory. And there is a good theory that inflammation is important in ALS. However, when we've tried anti-inflammatory drugs, not exactly steroids, but drugs even more powerful than steroids, they haven't worked. And I think the reason is the kind of inflammation that's evident in motor neuron disease like ALS is not, the location of the inflammation is not where the steroids can get to. Or the cells that are most involved in the inflammation are not the ones that the steroids are most responding to. So right now we do not use prednisone or other steroids for the treatment of ALS. Any other questions? Yes?
What is PEG?
PEG? Oh, I'm sorry. I guess I use the term so often. The question was, what is PEG? PEG stands for percutaneous endoscopic gastroscopy, of course. Right? That's why we call it PEG. It's an alternative way to get nutrition. What it is physically is it's a small tube about the diameter of a pencil. It sits on your belly. It's a way for you or a caregiver to deliver nutrition directly into the stomach, bypassing the swallow mechanism. Having a PEG affects, it doesn't cause any detriment. There's no disability by having a PEG. You can do everything that you could before the PEG. So we use it quite frequently because it's got so many benefits.
We have an internet question.
There's a question from the internet.
We have a question from the internet, which is, are there more centers like yours in California where people can get multidisciplinary care?
Yes. Along with this influx of clinicians and clinician scientists in California, there have been many centers. I try to name them all, but if I forget one, I'll feel badly. So sufficing to say that they're in every major city. San Francisco has several. Los Angeles area has several. San Diego has one. There are a few voids in the state. Voids mostly in the eastern parts of the state don't have large multidisciplinary centers. And along that line, just recently, last week and the week before, I've taken possession of a new device in our clinic which will allow us, hopefully, to do telemedicine to link to these outlying clinics or populations of folks that can't physically travel to Fresno to get care by us. And we'll try to do this electronically in conjunction with their practitioners if I can get enough cooperating practitioners in their field. But yes, there are multiple clinics. Of course ours is the best. You knew you were going to ask me that. There are multiple clinics that are excellent throughout the state. Many of them have been around, all of them have been around longer than ours because this is fairly new in Fresno. Other questions? Okay. John, do you want to?
Want to introduce your team?
Who's starting? Okay. So I'd like to introduce Will Freeman, who is our physical therapist, one of our physical therapists, the one that you always see when you come into our clinic, and he's going to start the presentation.
So good afternoon. Like Dr. Rosenfeld said, my name is Will Freeman. I'm the physical therapist here on the staff at the Neuroscience Institute. I've been practicing here in Fresno physical therapy for over 7 years now. I recently joined Dr. Rosenfeld's team about a year ago from today. Thank you. And though I may be one of the newer members, my purpose kind of today is to tell you why I'm the most important person of all the ones that you're going to listen to today. As Dr. Rosenfeld talked to you about, one of the cardinal signs of ALS is weakness. And in 75% of the patients, that weakness will start off in either your arms or in your legs. And I'll tell you, there's nobody here that is better equipped or better trained to be able to evaluate that weakness. And one of the things that I like to do, or that I can do, is take that evaluation and say, okay, so maybe you're weak here, but be able to apply that weakness into how it's going to affect your daily life. But that's enough about me. Let me get to you the real reason why I'm here. The 2 key points I want you to remember, and these are things that I think everybody who has ALS or everybody who knows somebody with ALS should know. And Dr. Rosenfeld touched on some of these, and I'll be explaining some of the things that deal with me a little bit more in detail. The first one is that it's better to be proactive than reactive. I can tell you, as you meet people in our team, you will get this impression from each and every one of us. And this isn't rocket science. We all know in every aspect of life, we're going to face challenges. And I don't know about you, but I'm not a big fan of things that come up unexpectedly. I like to know ahead of time what I'm going to be facing so that I can start preparing how am I going to make it better. What am I going to do to be able to handle this problem that comes along? And a lot of times, a little bit of preparation makes a big difference in the outcome. And I think that's why Dr. Rosenfeld was talking about this concept about fear. Because as you're afraid of certain things, a lot of times we're mostly afraid of the unknown. And sometimes just knowing a little bit more about what we have and what we do is a big help in calming those fears down. So we can start to think about, okay, I have this disease that's pretty serious, but what are my options? What can I do to help make things a little bit better for me? The second thing I want to talk about is that there are hopeful alternatives. In every aspect of your disease, no matter where you're at, no matter how severe your weakness becomes, there are alternatives that we can recommend to you that would help you maintain the mobility and keep you doing the things that you want to do that are most important in your lives. So what are those problems? This is a list of some of them that I pulled together myself and with my colleagues. I already mentioned the weakness. You'll hear a little bit more today about things like dehydration, difficulties with talking or swallowing, difficulties breathing, something as simple as producing a cough, and Urban's going to talk a little bit about how important that is. All of these problems, in some way or another, can be proactively managed. And I'm not saying that we're going to be able to fix them all. I'm not going to be able to say that you're going to avoid them, because certain things with ALS are unavoidable. But again, the message is that there are things that you can do to lessen the effects, the detrimental effects in your life that come from these different problems. So let me get to the point that I specialize in, and that's with the weakness. Weakness with ALS usually comes from 2 different sources. When you look at function and moving around, things like that, weakness is usually a 2-part process. The first is the nerve damage that Dr. Rosenfeld did a really good job of just showing you. That part's unavoidable. It's going to happen. But one of the things that you may or may not know is that damage usually will start in focal areas. It doesn't just immediately hit every single muscle in your body and you start going downhill from there. It starts off in isolated areas. And a thorough physical therapy evaluation can help you identify what those areas are. How does this help, you might ask? If you know where your weakness is, we can give you recommendations on what you might struggle with. So for example, Dr. Rosenfeld was just talking about diagnosing patients and making sure they're grouped together with similar types of patients. Am I one that has more weakness in my arms or in my hands? Am I one that's going to have more weakness in my swallowing muscles or in my legs? And as you heard him say, the difference in your experience with ALS is almost completely different depending on where those things happen. A lot of us, it would be nice in life if we walked around with a sign over our head saying, these are the problems that are going on in my body. But we don't have that. We don't know until we start to lose things that something's going wrong. And the sooner we're able to identify what those things going wrong are, the easier it's going to be. The second part of weakness is this term called disuse. Now, disuse doesn't just mean that you're not doing anything, because most of our ALS patients are doing a lot of things. But one of the things I'd like to present to you about disuse is this idea of compensations. Compensations are things that we tend to do sometimes without even thinking about it. So for example, a patient who has weakness in their legs, as their weakness progresses, walking might get to be a little bit more difficult. And as they start to get unsteady, you'll start to see they'll reach their hand out to grab onto a piece of furniture. Or maybe they'll change the way that they're walking by widening their feet out or turning their feet out so that they can feel a little bit more stable. Oftentimes, these are things that patients will do without even necessarily consciously recognizing it. They're going to do it because they're going to avoid falling. And the amazing thing about our body is it'll fix some of the problems that you're experiencing without you even recognizing it. Some of the things like reaching out for the furniture and stuff like that, some of those things we're going to do consciously. But if you do that over 2 or 3 months, a few weeks, pretty soon it's going to become habit. Pretty soon it's going to be something that you don't do, that you don't even realize that you're doing. And again, a thorough physical therapy evaluation can help you to identify those things. Sometimes we may promote that. Sometimes we may want you to do that compensation because the last thing we want you to do is to fall. But we'll be able to help you identify areas where you can still maintain the balance or still maintain the strength or still maintain your mobility during that whole process. The second thing that I want to get across to you is that there are hopeful alternatives. Okay, I gave the example just now of balance problems. Okay, and one of the things that Dr. Rosenfeld mentioned that we are very, very proactive about is AFOs, which are ankle foot orthotics. But for the most part, think of them as an ankle brace, something that will slide into your shoe and provide a little bit of support to your ankles. I'll show you a picture of these in just a few minutes. We also are very early advocates of walkers. Okay. Now you might ask yourself, wait a second, didn't he just say if I hold on to something while I'm walking that could promote disuse? And you would be right in asking that question. However, a walker may allow you to do things that you may not be able to do before. For instance, if you're struggling with walking, you may be expending a lot of energy just trying to be able to get from one chair to another in your house that you may not have to. And a walker would be able to help you conserve some of that energy so that you can stay up on your feet, so that you can continue to do the things that you want to do. A physical therapist, regular visits with a physical therapist would be able to help you identify, well, what can I do if I have to use a walker now? What can I do to help make sure that I'm not losing some of these other things that I'm not using? So, as far as hopeful alternatives go, early on in the disease process, like I said, you may or may not have any mobility concerns. You may, it might be just a little bit of weakness here or there. Maybe you're starting to drop things more. Maybe you're feeling a little bit less steady, not so much on a flat surface like this, but things like stairs or going on, shifting on, walking on grass or unsteady surfaces. Maybe you're starting to notice a little bit of problems. Well, as I mentioned before, weakness with ALS starts out fairly focally. Okay? And one of the alternatives that we try to initiate very early on is this idea about exercise. And before I go any farther about exercise, let me let you know, there is some risk with doing too much exercise. There's studies done several decades ago about high intensity exercises. The studies that were done weren't specific to ALS, but they were done with similar motor neuron types of diseases. And they were shown to be a little bit detrimental. Okay? And then I just got done talking to you about how too little exercise also can have a detrimental effect. So then the question is, how do I know? What's the difference? And I'm here to tell you that I can help you. I can give you recommendations to be able to say, these are things that you want to recognize. These are things that you want to be able to do to help you recognize whether you're doing too much or too little. If you can do any voluntary movement in your muscle meaning even if you can't move the body part that you want to, but that muscle can turn on and off. I can tell you, number one, whether you are doing that or not. But number two, I can tell you what types of exercises you can do so that you can keep doing that as long as possible. So let me give you an example of something I actually just learned this weekend. We used to do manual muscle testing, well, we still do a lot of places, do manual muscle testing. And what that means is we put your arm in a certain position and we say, hold here while I push you down. I don't want to say push you over. Most of that is, let's take your arms for instance. So if I want to test your biceps here, I'll bring your hand up to a certain position, and then I'll pull down here at the wrist, and I'll kind of gauge how much energy or how much resistance I'm feeling as I pull your hand down. And then I'll give you a grade. And we used to do like 5-point grades. And we're starting to realize that those 5-point grades aren't good enough. They're too broad. It's not specific enough. Somebody might be able to say they have moderate resistance, and then another clinician will say that's moderate resistance. But how do we know that that resistance is the same? We don't. And they're starting to come up with new things that will enable us to test you, like I said, even if all you can do is turn the muscle on and off. Okay. So a moderate exercise program, this hasn't been studied yet in humans because there's actually a surprisingly small amount of studies that show the benefits or the effects of exercise in ALS patients. But they started to do this in animal studies. And like it says up there, some of the animal studies have shown that moderate exercise has actually been shown to slow down the progression of your disease. So again, we're not avoiding the weakness, but what does slow down mean? It might mean that you're doing things a little bit longer than you want to. And when you're talking about a disease as serious as ALS, you just heard from Dr. Rosenfeld how a few months can make a big, big difference. So as we go along, as the disease may progress, as you may get a little bit weaker, it's time to start talking about assistive or adaptive devices. Okay, the concept of AFOs and walkers, those are examples of assistive devices. I mentioned an AFO slips into your shoe. It helps you to feel a little bit more steady. Some of the AFOs now are made out of materials that will enable the material to store energy inside of the AFO and be able to give you a little bit more push off as you bring your leg forward. We have a patient who, in one of our Pleasant clinics recently, he's still working, he's still doing a lot of things that he wants to do, and he told me recently, I'm glad that I got these AFOs. He hadn't had them. Nobody ever talked to him about doing AFOs because he was walking around, because he was fairly mobile. You look at him and you could tell maybe that something's wrong, but certainly nothing serious. But putting these devices into his shoes are the difference between him continuing to go to work and support his family. Something that small can really make a big difference sometimes. Again, walkers. Okay, when you look at walkers, and I mentioned earlier about the fatigue that happens, there's a big difference between sitting around your house and getting in your house and being able to just walk outside. Okay, some of the walkers, as I'll show you, that we like to use, they're called 4-wheel walkers, and they have a seat on them. So, as you're walking, you could sit down somewhere. You don't have to wait and hope that the city maybe has a bench or somewhere close by that you can sit down. The other benefit is the seat on those is a little bit higher. I'm sure some of you will see that getting up out of some of these chairs, it's a little bit harder to get up out of a lower chair than it is a little bit higher chair. So again, the appropriate times for that assistive device, I know walkers, I know AFOs, things like that are not the most appealing thing in the world to think about. But at the right time, I won't have to explain to the patient why it's going to help. They're going to feel it as we try it out. So these are some of the alternatives that I was talking about. This right here is an example of the AFOs. Okay, I don't have a picture of the walkers because we have a nice example of I'm actually jealous of this walker. Of the way the walkers can get around or help you in your movement. As you get to where standing maybe is a little bit more difficult, or maybe walking is a little bit more difficult, some of the alternatives that we use in the clinic is this here. It's called a standing frame. It's just one example. There's several companies that make them. A standing frame can literally help somebody who cannot stand on their own to be able to stand up. This particular device actually starts off looking like a chair. And so you can use a lift or something to get the person into the chair, or maybe a transfer. Maybe they can't stand very long, but they can stand up and move and sit back down. If they can get into the chair, then the chair will do the rest and they can stand up. Is this important? Absolutely. We talked about the fear and the psychological effects of having ALS. Well, we've also had patients who just being able to stand up again for a few minutes makes a big difference in their life. There are also medical benefits. You'll hear about breathing and things like that. As we sit for a long period, the muscles in our ribs will be a little bit contracted. It'll be harder to breathe. We saw from Dr. Rosenfeld's talk about how important it is to be able to breathe, to keep those lungs inflated. And being upright will help you to be able to do that. So standing frame is one of the things that we do. The other thing that we like to do is this here. It's called a light gate system. This light gate system, it uses a harness around the patient so that we can take off a certain percentage of your body weight. Let's say you can't lift your legs anymore because that weakness is progressing. Well, as we take off some of your body weight, maybe you won't have to lift all of your legs. Actually, more importantly, when you're walking, ironically enough, it's not the leg that you're trying to lift that's the difficulty. It's standing on the other leg while you lift the other one. That often is the biggest problem. Because if you think about it, you have to transfer all of your weight onto one leg to be able to get that other leg to move forward. And if you can't do that, something like a light gait therapy will be able to take off some of that weight so that you can still walk under your own power. Even if you can't, we have the opportunity to have a therapist like here sitting right next to you. Imagine this person over a treadmill, and we can help move that foot for you. So you can still maintain a lot of the cardiovascular effects and the breathing effects that are beneficial from exercise. You may think I'm confined to a chair, I can't do moderate exercise, but you really can thanks to devices like this. And of course, as things go along, the discussion of power equipment, in particular power chairs, will come up. Okay. Again, these things sometimes are unavoidable, but they're also not a prison sentence. Because you have to get into one of these is not something that necessarily means bad things. I have a patient recently who, he had a lot of weakness, and he was actually one of those faster progressing patients. He came into our clinic and he was walking fine, and we asked him, what's the number one thing you want to do? And he said, I take care of two of my aging aunts and uncles, and I just like to cut firewood because I live up in the mountains, and I'd like to make sure that they're comfortable. As his weakness progressed, obviously that got harder and harder, and where he wasn't able to do that. He was still able to stand, he was still able to walk, but he wasn't able to walk very far. It got to the point where he was walking, maybe the length of this room, and he was done. He was tired, he had to sit down for a while. Well, as we were talking to him about getting to know him, we found out he was, I don't want to say an avid fisherman because that would imply that he was good. I could be an avid fisherman, but I never caught anything, so I can't claim that. But he really liked to fish, and all of this process of him dealing with this weakness, if he can't get out of his house, he can't go fishing. And so we discussed this idea of a power chair, even though he was still able to walk. With the power chair, he was able to get next to the stream. Actually, with this family, what they did was they hired a specialized boat, and they rigged something up where he drove his chair out to the boat, and they took the boat out into the water. Now, that may not mean a lot, or may not sound a lot, especially for people where that's not appealing to. But it just highlights how, with some of this power equipment, we can help you conserve the energy that you do have so that you can do the things that you want to do. Often as we deal with weakness, we give up some of those things that we want to do just so we can get things done, like eating, like walking, like getting out of a chair. Some of those things are so difficult for us that we give up even thinking about being able to do some of these fun things. And so a proactive approach, early intervention, hopeful alternatives helps us to be able to do those things for as long as possible. So let me sum this up. Number one, it's better to be proactive than reactive. One of the favorite things that I've heard from Dr. Rosenfeld say was what he mentioned to you at the beginning. You have an incurable disease, but you do not have an untreatable disease. And there are plenty of hopeful alternatives for you out there to help you with your mobility. ALS patients deal with so many problems that they're going to face. that I don't think anybody should have to go through that by themselves. Thank you for listening. I look forward to taking some questions in a few minutes when everybody's been done participating in the forum. I just wanted to highlight my support staff there. They keep me going some days. Thank you very much. I'd like now to introduce Irvin. He's our respiratory therapist.
Hi. Well, my name is Irvin Marquez. I'm actually a respiratory therapist, and contrary to what Will said, I'm actually the most important. Well, why is that? Well, if you can't breathe, you can't move. A lot of patients tell me, Irvin, I don't need to see you because I can breathe fine. I don't need to see you because I only wake up with headaches in the morning. Or I wake up frequently at night. I don't need to see a respiratory therapist. I aspirate or I choke on my saliva. I don't need my teeth. Well, what do I do as a respiratory therapist here at UCSF Fresno? I manage the airway. I also manage ventilation, invasive and non-invasive. So airway management. We want to make sure the airway is clear. Also, we want to make sure the lungs are filled with air, in and out. For ventilation, we focus on non-invasive, which is CPAP or BiPAP therapy. Well, why are we proactive? Great example. Last night, I was not proactive. I actually used the last toilet paper roll. And this morning, I paid the consequences. There are different mask options out there also, and for me, as a therapist, I'll adjust your machine if you have issues with it. So let's talk about the muscles. Obviously, that's not me anymore because I shaved my mustache, but Dr. Roosevelt and I, we actually met at the gym. But seriously, the muscles I want to talk about are your diaphragm and intercostal muscles. The diaphragm muscles move the air in and out of the body, the lungs. But what happens if the lungs get weak or the diaphragm gets weak? As a respiratory therapist, what I do is I actually check the function and strength of the lungs, or the diaphragm and intercostal muscles. I measure with forced vital capacity and inspiratory capacity, or NIF, also negative inspiratory force. I can take that big breath in. What happens when the diaphragm becomes weak? Okay, the active breathing causes the respiratory muscles to fatigue, causing weakness. And what happens is respiratory failure or distress occurs. When I do my evaluation, I actually also do a full Epworth sleepiness scale. This scale tells me how sleepy a patient is. With that said, when patients come in and I do a spirometry test or a breathing test, they actually say they do a good job. Their breathing's fine. What I do is I do an Epworth sleepiness scale to see how sleepy they are. If they're sleepy, we do a sleep study. Why do we do a sleep study? Well, again, we're proactive. We want to get the patients on a CPAP machine or a BiPAP machine before they actually need it. Again, toilet paper. Normally when we're breathing, we breathe slow and shallow when we're sleeping, okay? Patients with ALS actually are more compromised. They have more awakenings. They're more sleep disturbances. This causes fatigue, headaches, memory loss, also poor cell and muscle regeneration due to poor oxygenation. This is not a typical sleep lab. Speaking of sleep lab, you guys know Lady Gaga? She actually had a surgery done at a local lab, and they couldn't wake her up, so they had to poke her face. The different machines that's out there, from a CPAP machine that's a basic machine, up to IVAPs or AVAPs. I'll go over the different machines later in the panel because I actually have them out on display. Different machines, different masks. So, what issues do we as clinicians and also patients have with the use of CPAP or BiPAP therapy? Well, it's just compliance. Patients have issues wearing the mask, but that's not a problem because there are multiple mask interface options out there, over 1,000, as a matter of fact, from nasal pillows for patients that are claustrophobic to full face mask for patients that are more obligate mouth breathers. Now, if you're a mouth breather and you're claustrophobic, no problem. There's a hybrid type of mask where there's nasal pillows that go right in your nostrils and also right in your mouth. Patients that have poor extremity use, they can't get the headgear over their head, or there's an oral hole, this goes fits right in your mouth. There's a mask also called a tap, which I have a sample of there, where it's a mouthpiece that has to keep your mouth closed, but also nasal pillows that fit in your nostrils. So there's no way for you to tell me, Irvin, I can't wear this mask. There's no mask there for me. I understand. We weren't born with a mask on our face. Okay? So I wear a BiPAP also, and it took me 4 weeks to get used to it. So there is an option. Now, patients tell me, Irvin, I can't sleep with it because my spouse thinks it's ugly, or my boyfriend or whoever. Well, it's sexy. It's so portable. You don't even notice it. Right? Patients that use the machine more often, these are the patients that actually use it. I've seen patients that actually start getting skin breakdown. These are for patients that use it for 10 to 12 hours a day because they're having respiratory issues. There's skin breakdown on the bridge of the nose, also indentations on the foreheads. There's an alternative. There's a machine called the Trilogy and also the laptop ventilator where we could incorporate sip and puff ventilation. It's more of a side wrap. So say you're here in the audience and you just need to take a deep breath. Well, we can take a deep breath. A lot of the patients aren't able to. So this machine, it's just a mouthpiece, will give you that deep breath. And it also has a 10-hour battery, I believe. Earlier I mentioned my full assessment. Well, one of my assessments, I actually have the patient's cough. This is for patients that can cough, but they can't get their secretions out. This is the best high-frequency chest wall oscillation therapy. Just think of it as a ketchup bottle. Okay? You get a ketchup bottle. Once you open it, you can't just pour it out. Well, this one you can't. You just squeeze it. But normally you would shake it. And I can't find my music, so I'm sorry. But normally you would shake it. You would shake it, and then the ketchup would come out. Same thing, same concept with this machine. It actually does vibrations to move the secretions from the lower airways up and out. Now, what if I can cough? Or what if I can't cough? Not a problem. There's a machine called Cough Assist. This machine actually has two functions for me as a therapist. I love this machine. It'll hyperinflate the lungs, like I mentioned earlier. It'll get the air in there, but it's also going to decrease your chance of atelectasis, that's when your lungs collapse, and it's also going to hyperinflate your lungs, because I want you to take a deep breath. And on top of that, it's going to mobilize your secretions. It's going to get any secretions down and out. So, again, what do I do as a respiratory therapist? I manage the airway. I make sure your lungs are clear. I hyperinflate your lungs. I want to make sure you get some good air in there and really expand your lungs. And usually hydration is an issue. Patients are dehydrated, so their secretions are really thick. And when I see that, when I speak to the patients about that, I actually speak to the dietitian, which is Claire, about, this patient's getting dehydrated, they need more fluid intake, so I refer them to the dietitian. Also ventilation, invasive, non-invasive. Why be proactive? Again, toilet paper. Remember toilet paper. I want you to get on the machine before you actually need it. That's why I do a sleep study. Again, it took me 4 weeks to get used to the machine. I don't want you to come and see me and say, hey, Irvin, I can't breathe, or you give me a call, because I give all my patients my cell phone number. or they call me up, say on a Saturday night, Erwin, I can't do what do I do? I usually say, okay, calm down, put your BiPAP on, and have your caregiver give me a call. Well, normally that person would say, well, I have my machine, but I'm not used to it. I don't have the right mask. That's why I say we want to be proactive and get you on this treatment. And again, there's thousands of mask options out there. I have some samples here. You can come see me afterwards and we'll talk about it. Pressure adjustments. There are 8 different machines out there. Multiple modes for different patients. This is my breath. These are my boys. Go Niners! Thank you. I'd like to introduce next Claire Diaz, who is our dietitian.
Thank you, Irvin. Thank you for having me. My name is Claire Diaz. I'm a registered dietitian. I'm a certified diabetes educator, and I work at the Neuroscience Institute here at UCSF. And contrary to my two colleagues, contrary to my two colleagues, I have the most important role in this clinic. Because if patients don't stay well nourished, they can't move, they can't breathe, and they can't communicate. Where else can you go and see a dietitian that in most cases is going to tell you to eat more? All right, we're going to talk a little bit. That's my sandwich is watching me. So today I'm talking about ALS and nutrition. And there's some key points I'm going to go over. I'm going to test you at the end too. So those key points are we want you to maintain your weight, avoid losing weight rapidly, and stay hydrated and drink plenty of fluid. Those are what we're going to talk about today. So my role as the dietitian is to help you maintain your nutrition status and your weight. So when you come in and see a dietitian, they talk about where your weight is today, where it's been, how are you eating, how has it changed over time, are you having chewing issues, are you having swallowing issues, are you drinking enough? If you don't drink enough, your secretions are thicker, as Irvin said, it's harder to get them out. If you don't drink enough, you get more tired, you get fatigued. If you don't drink enough, you get constipated. We don't want you to get constipated. If you get constipated, a lot of times you feel full and you don't want to eat. So I'll make some suggestions to help you with your intake. And I also talk a lot with our speech therapist, Erin, who you're going to meet next, to see how your swallowing is. So the ALS nutrition connection is well documented. People who maintain their weight and their nutrition do better long term. There's a measure called the body mass index, and it's a measure of height and weight. And we measure that every time patients come in. And we know that patients who stay between greater than 18 and less than 35 do better long term than those who are less than 18 or greater than 35. People who lose greater than 5 to 10% of their weight rapidly, or if their BMI is less than 20, have an increased risk of malnutrition. So why do people lose weight when they have ALS? Well, we think we burn more calories because we're going to talk to you about the diaphragm and how that diaphragm works to keep breathing. And so we think they burn more calories because they're using those muscles to breathe. They also may burn more calories just because of the disease process. We're not quite sure. We think they may burn 15% more calories than the person who doesn't have ALS. Also, people start eating less because they have difficulty chewing and swallowing. They may start cutting out foods. They may start cutting out protein. It's too difficult to chew. They can't swallow it. They may stop drinking fluids, okay, which makes them more tired. It takes them longer to eat their meals. So there's a lot of reasons why people lose weight. Dr. Rosenfeld talked to you about a PEG tube. We're early proponents of using PEG tubes. If you put a PEG tube in, even though you're still eating okay, you can use it for fluid. You can just use it for fluid, and then as time goes on, if you're not eating as much, then you can use something like Ensure or some other feeding or fluid between meals to help you maintain your energy. Also keeping an eye on the pictures. Right? These are some pictures in there that are interesting. So what should you do to stay well nourished? Well, make sure you're eating 3 meals a day. If you know you're eating less than you were before, make sure you have something in between your meals. If you're not eating enough protein, you should start to cut things out. There's some things we can do to help with that. Make sure you're getting enough fluid, because if you don't drink enough fluid, you get tired, you get dehydrated, you can't breathe as well, and you get constipated. We can do things to add calories and protein to your meal. Add butter, add margarine, add mayonnaise to your foods, add sour cream, add peanut butter, add avocado. Lots of ways to add calories to your meals. And if you need to, there's always supplements like Ensure, Boost, and that kind of thing, which we're going to talk about in a few minutes. Lots of fluids. Not all the fluids you consume have to be water. Especially if you're thickening things, people really don't like to drink thickened water. So if you have diabetes, because I'm a diabetes educator, if you have diabetes, maybe those fluids need to be sugar-free, but still you need to drink fluids. We prefer they not to be caffeinated, and we also don't count alcohol in these fluids. You can't get all your fluids from alcohol. So you can use Gatorade, you can use lemonade, you can use tea, all kinds of fluids other than water. So those liquid protein drinks, I have some up here. A lot of them you've seen in your regular grocery store. Your pharmacy carries them, Costco carries them. You've seen Ensure, Boost, most places. Okay, they're readily available. You can go onto the website for Boost and for Ensure. Sometimes they'll give you coupons. Now, some of these, again, a couple on the bottom. The glucerna right in the middle on the bottom, and the Boost glucose control. Those are for folks who have diabetes. So those can help you add some nutrition without raising blood sugar too much. Now there are several on here that Boost very high calorie, which is the one on the very left. The Nutrient 2.0, which is the one in the center, and the 2-Cal-HN. Those are 500 calories each. So if you're buying something, you might as well get more bang for your buck. If you're buying just a regular one, always get Ensure Plus, Boost Plus, or a generic Plus version. If you want something that's really high calorie, those are available either from Amazon or from the manufacturer themselves. If you like homemade things, throw some Greek yogurt in there, throw some peanut butter in there, either milk, soy milk, almond milk, whichever beverage. Throw some ice in there, you can make your own homemade ones. You can use the Carnation Breakfast Essentials as the base. But what I would suggest is you use a variety of them, because you don't want to get burned out on one. So if you know you're eating less, have one of these between meals. Okay, ways to add protein. So when patients come in and they talk to me, there's lots of ways we can add protein if they're not eating much meat. But if a patient comes in and says, well, breakfast is cream of wheat, lunch is a half a sandwich, and dinner is cereal, I know they're probably not getting enough calories, but they're also not getting enough protein. So you want to make sure that you get enough protein. So we talk to patients and we tailor things to what they need. So I talk to the speech therapists a lot about what's going on with our patients and how they're swallowing and how they're doing. But now when you come in and see our physical therapist, they may weigh you in between your visits with the dietitian. And you wonder, well, why is the physical therapist worried about what I'm doing as far as my weight? Well, the physical therapist is concerned because if you lose weight, a lot of times you have less energy to move. And so we work as a team. Irvin, when you see Irvin, he talks to you about that fluid. If you're not drinking enough fluid, you're going to get tired. You're going to have thicker secretions. They're harder to get rid of. You're going to get constipated. Okay? So we all work as a team. We all discuss our patients with Dr. Rosenfeld, with Tony, our medical assistant. with Nina, our social worker, and that's our multidisciplinary team to provide the best care we can for our patients. And we encourage our patients to call us in between their visits if they have any problems. So can you remember and tell me what those 3 things I talked about in the beginning, what were those key things I talked about? Anybody remember? Not losing weight rapidly is one. Staying hydrated and maintaining your weight. Okay. So the things you would have looked for on my slides were the camel drinking water and the scale. That was the clue as far as what I was talking about. So my key points: maintaining weight, avoiding rapid weight loss, and staying hydrated. Thank you for listening and for having me today. And I'll be back. Now, I know you're watching that sandwich disappear behind me. So hopefully you had lunch today, and hopefully you had snacks. Thank you for having me. You've been a great audience. And I will be back for our panel discussion. And now I'm going to turn it over to Erin, who is our speech therapist. And she's going to talk about swallowing and communication.
All right, let's figure out this little clicker works. All right. Well, I'm Erin Singleton, and I'm the speech language pathologist, or as most of you know, the term speech therapist. And these are my fellow colleagues in our multidisciplinary team. So first of all, let me just say that I love my job. Sometimes I feel a little bit guilty that I get a paycheck for it. I'm here to tell you today that I actually have the most important job on the team, contrary to what you've heard already today from my colleagues. Why do I have the most important job on the team? Well, because number one, not only do I have the coolest toys, as you'll see over here, but number two, what good is it if you can move the right way and sleep through the night breathing well and maintain your weight if when you get where you want to go, you can't communicate, right? So there's a couple things that I want to talk to you about, a couple key points today. And hopefully at the end we can touch upon them as well, and we can answer some questions in the panel portion of the discussion. So the first thing is that communication is a right and not just a privilege. Let me say that again. Communication is a right and not just a privilege. It's my job to make sure that communication is always a possibility, which brings me to my next point. There is no stage of disease progression in which communication is not possible, which is contrary to what a lot of people feel when they have ALS. So it's my job to make sure that throughout the progression of ALS, there's always an option there to maintain communication. So it's equally important for me to mention that in addition to working on communication with patients, I am always involved, frequently, pretty much always involved in the assessment of the function and the physiology of the swallow. A lot of people say, you're a speech therapist, why would you deal with my swallowing? Well, obviously speech and swallowing are they're interrelated, they're interchangeable, it's the same muscles essentially. So a few things I want to touch on regarding swallowing is the assessment. I usually start with just a basic assessment, evaluating the swallow, evaluating the risk of the swallow, how safe is it, and then I'm a fanatic about education. Teaching patients, these are the things to look for. I'm not going to keep it secret that I know if you're aspirating, or I want you to know what to look for. I want your family members to know what to look for, because quite often some of the things that we experience become a habit. So I would look at the safety of the swallow, and then some of the things that we might do to treat that is to maybe do some exercises or some compensatory swallow strategies. Change the foods that we eat, modify the textures of the foods, not necessarily eliminate, but just present those foods in a different way so that it's safer for your swallow function. I would definitely take a closer look at liquids. Anybody who has difficulty swallowing knows that that's usually the tricky part. It's usually the liquids that get us coughing and aspirating. And then in some cases, I may make a referral to a GI doctor if we're looking at something that's more esophageal, which is the tube that delivers the food to the stomach. We may chat with a GI doctor about possibly recommending a PEG tube, also known as a feeding tube. And we may do some necessary swallow tests to evaluate that. And then lastly, again, I always start and finish with education. I want my patients to know what to look for. So let me bring you back to my original point, Communication is a right and not just a privilege. And as it turns out, I'm not the only one that feels that way. In 1992, the National Joint Committee for the Communicative Needs of People with Severe Disabilities actually printed up what we call the Communication Bill of Rights. I like to call this my speech language pathology scripture. And as a speech therapist, this is my scripture. This is why I do what I do, because I truly believe that, as the statement reads above, all people with a disability of any extent, any severity, has a basic right to affect, through their communication, the conditions of their existence. So what does that mean? That means that we all have a right to dictate how we want to live our lives, how we want to spend our time, how we want to receive treatment, and how we want to interact with others. And we have the right to do so using our communication. So I won't list off all of the entire Bill of Rights, but I did highlight a few that I find pretty profound. And that the first one being expressing personal preferences and feelings. Another one is requesting and sometimes requesting and refusing another person's attentions or interactions or objects. We all have the right to be spoken to with respect and with courtesy. And my favorite one, I think, is we all have a right to be spoken to directly and not to be spoken for or in third person. And lastly, we all have a right to have clear, meaningful, and culturally appropriate communications. I believe in the Communication Bill of Rights so strongly that I truly believe that every hospital and nursing home or doctor's facility, wherever you go to receive care for your communication, should have this listed. Because sometimes we all need to be reminded that although the function of our speech might be changing, the intent behind our communication does not change. So in other words, even though it's harder for us to say what we want to say, the meaning behind it is still there. Our communicative intent is equally as important. So what is my goal as a speech therapist? Yes, I have some really cool toys over here, but not everybody needs those. Fortunately, not everybody needs those augmentative communication tools that I have. So in the beginning, and sometimes throughout the course of having ALS, sometimes we just need to tweak what we're already doing. And that involves sometimes using some compensatory speech techniques, like breath support, breath management. We never think about how we're breathing when we're talking, unless we're standing up in front of a bunch of people and we're nervous, right? So sometimes just training some little techniques to manage your breath support better when you're starting a sentence or spacing your words. Sometimes just tweaking it a little bit is key. Sometimes we treat articulation, which is the sounds, the actual sounds that we're making when we're speaking. Sometimes we need to slow the rate of speech, which is my big one. I have patients tell me all the time, "You're so excited. Can you slow down? You're going too fast." And then changing the volume of speech. That's another one I hear a lot too from my patients. They have to turn down their hearing aids when they come into my office. So in the event that these traditional speech techniques are not helping as much as they would have before, then we look at augmentative communication tools, which is quite a spectrum, and I have several things that I would love for you to ask me about if there's time at the end. So, augmentative communication is truly a spectrum. We go from the very, very low tech, or what I like to call no tech, like a communication board, to something very high tech, which might involve high tech technology, infrared cameras, Bluetooth, etc. And on the table displayed over here, I really do have a very large variety of things from low tech to high tech. So I have some pictures here of some low tech items. Sometimes, actually very frequently, during our ALS clinics, patients walk in with a yellow legal pad and a pen. So a piece of paper or a dry erase board sometimes, which is actually a step up. And the first thing I like to do is say, okay, let's get rid of that. There's easier things, there's smaller, more lightweight things, more functional things for me to suggest. And there's an example up there of an LCD writing tablet, the boogie board writing tablet. It's basically a tablet. It doesn't store your messages, but you can use your finger or anything to exert pressure to write what you want to say. And sometimes a person's speech is pretty intelligible or clear, but we just need a little bit of a boost. Can you write the word you're saying? I'm missing that first letter. Sometimes it's just a volume issue because maybe airway management is difficult, so it's hard to project your voice the way that you did before. So I might just suggest a voice amplifier, like I'm using right now to amplify my voice. This is an example of a very basic communication board that speech therapists in the hospital quite often give to the patients to have at their bedside if it's difficult to communicate. But sometimes our patients at home just have one of these stuck next to their bedside table if they just want to quickly point to something that it's difficult to convey. This is a clear lucite eye gaze board. I don't know if any of you have seen this before. I unfortunately lent out my very last one. But what it is, it's partner-assisted communication. So in other words, if I'm chatting with somebody, a person that has ALS, and it's difficult for them to communicate verbally or point, then what I would do is I would hold the board in front of them, and because it's a clear board, I would look to see where their eyes are looking on the screen, whether it's a word or a letter. And I would move the board accordingly so that at the point where our eyes meet, that's the letter or the word that they're looking at. And that's a very low-tech but very clever way to communicate. If you don't have a fancy communication board, let's say, or communication device, let's say you have one but the power is out or the battery is dead, this is an easy way for you to communicate. Now we have very high-tech devices. There are several different companies that I work very closely with that manufacture these high-tech speech-generating devices. There's a picture of an iPad up there. Many of us have iPads at home. There are several applications available that are speech-generating applications to use on the iPad. The coolest thing about some of these, the more high-tech devices, is that they have environmental controls. What that means is that they are equipped with Bluetooth and infrared technology that allows you to not just request how you want your coffee in the morning, but also turn on your television and surf the internet or make a telephone call. So it's pretty comprehensive. So how do we access these devices? It doesn't do us any good if I get you a really fancy computer to help you communicate, but then you have no way to access it. So sometimes we might start out with a computer or a speech generating device that we operate by just touching the screen. But in the event that this finger doesn't work so good anymore, then I'm going to get you a different access point. There are access points that we can trigger with any muscle in the body, or even any lack of muscle. We'll get into some of that in the discussion, hopefully, but there's infrared switches, there's chin switches, the very bottom picture in the center, I have a pointer, right here. This is a microlight switch. It literally requires almost no pressure to activate this. There's pillow switches to have at the bedside to possibly roll over and alert your family member or your caregiver that you need help. Up at the very top, this kiddo right here is wearing a ribbon switch, which requires very, very little muscle movement. And then this is a head mouse, which I have on this page right here. A head mouse uses a wireless optical sensor, which tracks a tiny little target that you wear on your glasses, your forehead, your nose, wherever you want to wear it, and it becomes the cursor on the communication device to actually select the icon that you're looking for. So, keeping in mind, after an evaluation, all that I've now learned, I come up with a plan. What are we going to order? What are we looking at? What sort of treatment techniques are we going to use? And if that involves an augmentative communication device, then that's also going to involve learning the device. So that's something that we like to emphasize as a team quite often, is that we're not going to get you a fancy wheelchair or a cool speech generating device and then say, good luck. Well, what that means is that we're teams, and we're not going to leave you hanging. We're going to train you how to use these devices, and not just you, but your caregivers, your spouses, your kids, your friends, people that will be working with you. I included a couple points up here regarding education and treatment of a speech-generating device. And the reason I included these is because I do remind patients that a speech-generating device is never going to replace the natural flow and prosody of your natural speech, or the natural speed of your traditional speech. But it's getting pretty close to doing so through things like rate enhancement, navigation, word prediction, expansions. So that brings me full circle back to my original point. Communication is a right and not just a privilege. So I'll remind you again, we're a team. We're a multidisciplinary team. And even though my job is the most important, there's nothing that will happen in the stage of the progression of ALS where we will tell you that there's no helpful alternative. Again, there is no stage of disease progression in which communication is not possible. So we've been joking. You've heard each one of us come up here and tell you why we are truly the most important job, why we have the most important job on the team. But the fact of the matter is, the most important person on the team is you. It's our patients. We truly believe in a collaboration between patients, families, physical therapy, respiratory therapy, dietitian, speech therapy, clinical social worker, and I guess the physician too. And really designing and tailor-making a plan for you, a treatment plan for you. We have a picture down here of our team that we took a while ago, but we didn't think it was a very good picture. It was someone took it with their cell phone. So we traditionally call ourselves Dr. Rosenfeld's minions. So we hired a professional photographer and they went ahead and took this picture of us. So I would like to take a minute to introduce our licensed clinical social worker, Nina Bartley Bates. She is going to come up here and chat with you a little bit about what she does for our team. Thank you so much for having me.
So I'm Nina, I'm the licensed clinical social worker here, and I'm actually, my specialty is in behavioral medicine, so I wanted to talk today about why it takes courage, compassion, and connection to not only deliver patient-centered multidisciplinary care, but to receive it. And let's see. How do we move this thing? I didn't do the run through, so is it this? Yeah. Okay. Right there. All right. So when all else fails, quote your chief a few times, and all will be good. Dr. Rosenfeld's one of his major quotes is, "If you get the head in the right place, the body will follow." Shakespeare said, "It is the mind that makes the body rich," and that was from the play Taming of the Shrew. But we found that in this work, I've been here about a year, and it's been a really steep learning curve because I've been a clinical social worker for about 21 years, and this particular work it's very challenging, and so I expect really that the challenge is mostly on the patients for this disease. Paul Wicks is an ALS neuropsychologist. He's been for many years a neuropsychologist out of England. He's probably well known to Dr. Rosenfeld. He's probably seen him at quite a few conferences. And he came up over the years. This is what he's noticed about patients: that there's coping styles with ALS patients. There's the information avoider, and that patient might be saying, "No thanks, I'm fine. Don't think I have ALS anyway. What's your problem?" The selective seeker kind of response, coping response, is, "I may have ALS, but I'm fighting this disease on my own terms and on my own time, making my own decisions." Not bad. It's close. And then there's this group of active seekers, which Dr. Wicks said, I'd like to kind of reframe it a little bit and say proactive responder. This patient would say, "I recognize it's got me, but I'm all on this patient-centered, multidisciplinary, proactive treatment deal. This thing has hit me like a ton of bricks, but I'll roll with the punches as best I can," and the patient continues to adapt over time. We can think about that as either discrete categories of coping, or we can think about that as kind of a very fluid, stage-wise thing. And so in behavioral medicine, what we're looking at is we're seeing people dynamically changing all the time. The mind is constantly adapting to whatever it's facing. And so my hope as a behavioral medicine specialist is to see, along with the team, whatever I can do to help patients move to that proactive treatment response. So for the patients out there, this is a kind of a picture of a first responder, got a baby, who's running from a fire. Are you an information avoider? Are you a selective seeker? Or you're a proactive seeker or proactive responder? And That, kind of like what Shakespeare was saying, it's the mind that makes the body rich. What is the shrew? That came from the play Taming of the Shrew. Today I want to answer that question, or at least begin to answer that question. What is the shrew we're talking about, and why tame it? And so this is going to be the only time in the whole little 10 minutes, hopefully, that I talk that I'm going to actually read this out, because it is really the crux of, what I'm trying to convey today. That ALS treatment decisions place high demands on executive functioning. Just when overactivated stress response, that's those things that are coming at the person with ALS that are creating that fear, that survival fear that Dr. Rosenfeld talked about. Dr. Rosenfeld talked about fear is the most severe disability. It's a disability of the mind, but it's temporary and it's controllable. That survival fear, that panic, that existential angst, those messages are being fired at from lower parts of the brain to the upper part, the prefrontal cortex. And it potentially can misdirect and distract and distort the messages that you might be hearing from the multidisciplinary team about the hope, about all of the devices that we can do and all of the techniques that proactive medical treatment can offer. And so because ALS requires that higher reasoning, these higher reasoning decisions to be made, ultimately integrated and processed in the prefrontal cortex. This is your mind on stress. This is kind of my area of interest. What can I do to help the patients feel like they can be in control? They are in control. The patient is the center of the multidisciplinary team. So there was a study done in 2012, and they looked at different patients, treatment team, other multidisciplinary teams. They were all multidisciplinary teams focused on ALS treatment, and they came up with 3 basic categories that they find make it difficult for patients to make decisions. And these questions were something like, in the beginning, who cares? Who knows? Who knows what to do? And when the choice was made for treatment with a patient-centered multidisciplinary team, the choices became easier because you did have experts to talk to. Another major question that this study brought up was, why me? So the patient's philosophy, their outlook on life, their perceptions of control, and a plan for action versus staying with indecision. And finally, the big question that we all ask, where's my place in this universe now that I have this disease? There's the diagnosis reaction, there's the response to losses, and there's the engagement with the team. That's the hope. So losses I've found in the year that I've been here, it's one thing that patients might start out being proactive seekers of treatment. And then when a loss that happens, it might be a PT loss, it might be something related to what Claire does, or what Irvin does, or what Aaron does, it kind of becomes a game changer. And that's where, again, in behavioral medicine, where we want to look at how can we help this person reevaluate and respond and lower their stress so that they can begin to have proactive responses. So I have this kind of a weird question. I'm going to ask you, which ambulance will you take? So there's this ambulance. This is probably the most common kind of ambulance that, if you call 911, what you're going to get. This ambulance, though, is very conservative. It's what you expect. It's reliable. It might be what the kind of response you'd expect if you did a Google about ALS. The problem with this ambulance is it gets stuck in traffic. This ambulance, my husband happens to do this one. He's a helicopter pilot. This ambulance is also a good choice. This one I would say is like the selective seeker that was talked about earlier. They'll zoom down for just the treatment that they want, and then they'll zoom back out. The problems with this kind of ambulance is it may be fun and exciting, but when and where will you land this helicopter? Helicopters can't land everywhere. And strangely enough, I vote for this one. This is a proactive ambulance. This is a first responder ambulance in Israel. I think that this is a good example of a patient being a proactive seeker or a proactive responder to ALS treatment. It hits all the points that I talked about when I first started. It's about compassion, courage, and connection. The story behind this, I think I have it in my appendix, but it's a man named Eli Deer had actually was 17 years old when he got this ambulance started in Israel. He found that this ambulance wasn't working. This ambulance got stuck in traffic. This ambulance, by the time he, as an EMT at 17 years old, would arrive on the scene, the patient often was too far gone. This ambulance doesn't work so well either. But this one, he came up with this idea, and he's able to go anywhere, go around any crowd, and he's able to get there where he needs to go. And I think that this is the kind of ambulance that I would like to see patients with ALS consider calling on. So, do you want your treatment, this proactive treatment we've been talking about, to be like a series of free falls where your medical team is there to catch you, proactive treatment, or more like a series of disappointments in which you ultimately feel unsupported? And your choices are important as a patient and a patient family, because timely patient decisions can make all the difference. I know we all talked about proactive treatment. I mean, sometimes intervention will be called on by Dr. Rosenfeld a little sooner than the patient might think they're ready for. But he has a reason for that. The team has a reason for that. Proactive treatment leads to treatment adherence and the best and highest quality of life for you and your loved ones. And this was a picture from the London Marathon. I thought it was really cool. It's one of Dr. Rosenfeld's, also one of his favorite quotes, is that we're in for a marathon, not a sprint. And proactive support, in this case it was a faltering runner in the London Marathon that was helped toward the finish line by his fellow competitors. And one thing that I did want to say, that I know each of the team in their own way has said, of course they said that they were the most important in the team. We all know that I'm the most important in the team because I'm the last one up, right? You always put the most important one. Fear is the most severe disability. Dr. Roosevelt said that. So it is settled that I am the most important person on the team because I deal with fear. But I did want to just mention this quickly, that an intervention that I might weigh in on, like everyone here had some kind of intervention, is dealing with fear, dealing with anxiety. We could choose Freud's model. You know, it's kind of a favorite of mine, but it's very complicated and it takes a while. And I'm not sure anybody really wants to be in 7 years of psychotherapy. Or you could do the thing, you could take a pill. It could be a pill for every ill. One of the big psychiatrists of depression and stress is Beck, Dr. Beck, and he says that we over-evaluate danger and we under-evaluate our ability to cope. And something that you're going to get from every single person on this team, and especially including Dr. Rosenfeld, is supporting your ability to cope. In studies, this is just one of many studies in 2006, that they studied anti-anxiety medication. I've got some typos on here, but benzodiazepines are used frequently. Antidepressants have been found really helpful. But when both behavioral therapies and prescription medications were tried, it was actually behavioral treatment that was durable over time. I don't know what that N is, but and CBT is one of the things that I do, cognitive behavioral therapy, and it more consistently yields a larger effect size. In other words, just averaging over many different circumstances where people feel stress, feel anxiety, it's most helpful. So I wanted to just leave you with a few ideas. A proactive response is the thing that the patients do. We can provide proactive treatment, or we can provide proactive support, but a first responder, a proactive model of treatment involves the patient having a proactive response. And that's, for us, that's to keep the I in team. You know, I know that frequently they say there's no I in team, but we say there is. The I is the patient, the most important person in the team. And first responders, like my husband, who flies the helicopter, and he's a medical rescue pilot, they get the idea of the buddy system and the team system, but they have to remain independent thinkers. That's what we want from our patients, is to be independent, to think independently, to ask questions when they're afraid to talk to the team about it. We're asking that patients are proactively prepared, that they learn, just like a first responder, that they learn to organize under high stress, because they've already prepared under a low stress or a moderate pressure conditions, like something like when you come into the clinic and you talk to us and things are going pretty well. That's the time to be really listening to what the team has to say, and we need to be really listening to you. And so the third idea is to be relaxed but focused. That's easier said than done, because the higher the stress, the more intensely the focus needs to be falling back on that training, that knowledge, and that experience. So to just kind of recap, keep the I in team, be informed but not Googled. Dr. Rosenfeld had mentioned people going on the internet, and they have all kinds of misinformation that happens. We're asking that you be informed, and also that from my perspective as in behavioral medicine, that you listen to ways that I can help, maybe help you regulate your stress and help you focus, and the most adaptive, responsive human connection possible is that when you have a need, that you talk to us about it, and that especially when it comes to things that you're afraid of. So that's that patient-centered multidisciplinary team model, and to make it kind of a little bit of psychobabble here, to be fully present in the moment, doing all we can to live the highest quality of life. Thanks. And so now we're going to do our question and answer. Thank you. You all amazing. I've learned a lot. Appreciate you all being here. Okay, we're going to open it up to questions right now. And perhaps maybe you can demonstrate some of the equipment if we have about 15 minutes left.
I have kind of a question that may concern a couple up there. Were you a family member? I have a patient with a feeding tube, and she still wants to take food by mouth occasionally. I've asked her, no doctor or no follow-up test. They never told her not to. But she has choked occasionally. So a family member, I'm a carrier, has strictly forbidden her from taking anything by mouth. And I understand his concern is fear of her choking. But the patient is completely mentally competent. And to me, it would make more sense for one of us to be present rather than her to wait till no one's around to eat something. That way, if there is a choking issue. Is he being overly cautious, or were you just family members who have the fear? Like them and the nutritionist, and we'll go to the nutritionist next Friday, and I'm going also with this family member, so I'm hoping we can kind of address them with the
Well, I guess I could touch on
tact
that.
for everyone.
Are these? Okay. That's a really good multi-part question, and it's actually not one that's uncommon at all. We do hear that a lot. So my first question, I guess, for you is, the patient has never had a swallow evaluation before, and is it in plans to do?
is the patient.
Oh, okay, hi.
She has not had swallowing evaluation, but he has told the team caregivers or what to
Yeah.
do. That do not let her do this.
Oh, I see. That's a predicament.
Like, kind of,
Yeah.
I want to.
So, as a speech therapist, what I tell patients all the time is, listen, I'm going to make my recommendations to you. I'm going to tell you what I feel in my professional opinion based on the findings of your swallow study is safest for you.
Mm-hmm.
And I'm going to educate and tell you, this is not so safe, this is safe, give you pointers. But ultimately, it is always up to you. It's always up to the patient to decide how much you want to push your safety, as long as you've been equipped with the knowledge of the risks behind the choices that you're making. So I would encourage you, and anybody actually, to find out really how unsafe it really is to be swallowing, because quite often our assumptions are that everything is unsafe, and what we find is there are some textures that are still enjoyable, very enjoyable to take by mouth, but are within the constraints of, the safest possible swallow. So if I were to speak to your family member, I would probably say just that. It's always up to you. You are, like I said, I spoke about in the communication aspect of my presentation, it is your right to make those decisions for yourself, but I would encourage you to really know with evidence, how safe am I, what's not safe, and then maybe just find a place of compromise in between and figure out how you can still enjoy the foods that you want in the safest possible way. I hope I've answered your question. Is there any parts that I missed to that question?
Because I learned a lot from what all of you said, and that was one of the things, because we are going to San Francisco nutritionist next day.
Yeah.
So I'm going to have some things written out. Try and reassure him and reassure, because
Absolutely.
as the caregiver, but I'm also a family friend of all.
Yeah.
He's my boss, but I've known him since he's 10. But yeah, I understand.
I think there's always a safe place there where we can. There's the best of both worlds where you can still enjoy food, but do so in a safe way.
Work out ways to do it.
Thank you for that
Thank
question.
you.
And I think making sure when you eat to chew so slowly, take your time. Sometimes we get in a rush, and that's something that we have trouble as well. But I think what Erin said about getting the swallowing out first, and then where you go from there.
And then you can see it when you don't feel like you have enough information.
Any more questions?
Fluids you can overload on fluids, and I'm wondering how do you determine how much to give to the patient, or how much will you allow the patient to take?
Do you mean by mouth or just in general? How much intake?
In general.
Well, usually in general, when I see a patient, I'll make a calorie recommendation. So say the patient's calorie intake is 1,500, and it's a calculation, we divide that by 240 because that's how many meals are in a cup. So 1,500 calories, 1,500 meals divided by 240, that's about 6 cups in a day, generally speaking. That's sort of how I decide how much fluid somebody needs.
Can you repeat that?
Oh, we have an estimate of how many calories somebody needs, and that translates into milliliters. That's a volume. And if you divide that milliliter by 240, that's how many cups. That's the answer to your question. So the more calories somebody needs, theoretically, the more fluid they need.
Are there any markers that somebody
If you notice that somebody is, their legs are distended, or if you press on the legs and there's an indentation, they may be getting too much fluid. Food too, if you have a soup that has part fluid, fruits and vegetables are part fluid as well. So you do get some fluid as well. So not everything, and not everything we consume, like anything with caffeine, of course, we don't count as fluid. Beer and wine we don't count. So did I answer your question?
Thank you.
Very well done, everybody. Thanks for your information. I was going to ask you, I lost my train of thought when she walked over with this. Somebody had mentioned, I've heard before, where, you know, some of the formulas that people drink or put in their peg tube, sometimes when they burp, it's pretty foul tasting, I guess. What do you ever recommend putting anything in it to make it taste a little better if that's happening?
Well, sometimes if people have trouble with usual formulas, we may just go to Ensure vanilla, so that they have a better taste. So it's just trial and error formulas.
So you wouldn't put like vanilla drops or something?
You could do that. If it's a problem with reflux,
yeah,
then they may need a medication for the reflux.
Right.
If I could just touch on that a little bit as well. You know, we tend to think that because we're bypassing this area with a peg tube, that it's somehow settling differently in our stomach. But in fact, we're just bypassing this area. So just like we belch when we, you know, eat something that has carbonation or something that's too acidic, and we get that kind of yucky taste in our mouth, it's also important, like Claire touched on, to evaluate whether or not it's just a belch coming up because of the natural gases in our body, or if we're having reflux because of the position that the feedings are being delivered. Because it is important for us to educate people on, if you have a pig tube, to not, I mean, we wouldn't eat laying down traditionally, so it's also important to watch the positioning of how we're using those liquids or putting those liquids into the feeding tube, because if we are laying completely flat, sometimes we can get that reflux, and then what we're actually working on is food coming back up versus just, you know, a typical belch.
And how fast the formulas are administered to. If they're going too fast, perhaps, or if you're getting air in between when you're rinsing, you can be getting air in that can cause slower feedings too.
Any more questions? We have time for a few more questions. Oh, hold on.
We have a question from the internet, and the internet question is related to communication. And the question has to do with low-tech versus high-tech communication devices. And the question is, do you recommend using tablets as a both low-tech and high-tech communication device?
That's a multi-layered, there's a multi-layered answer to that question. Tablets can be really awesome devices, not just for communication, but just for fun. There are a lot of readily available speech applications on the Android tablets, just the tablet market in general, that can start out to be very helpful. Some just are, you know, writing, like I discussed, using low-tech methods like writing to clarify what we're saying, all the way up to typing what we're saying, all the way up to having a specific speech application that has predictive messaging or phrases that are common in our speech. So a tablet, yes, can be an excellent tool for graduating from low-tech to high-tech, moving up, changing the applications that we're using. But there are some downfalls, and that is the ability to adapt that tablet as our body changes, as the disease progresses. There are ways to do so. In fact, there are several speech therapists out there who have recently been chatting about ways to use Bluetooth technology to adapt a switch, like you had seen in the pictures before, to operate the switch to use the tablet as your high-tech device, to continue using what you're comfortable with as your speech method, but adapting it with Bluetooth switches and things like that to activate with whatever residual strength there is. The downside to it, there's a few things. The downside to it, sometimes on my part, can be funding, because insurance doesn't cover tablets as a speech device or as durable medical equipment. The other downside is that they can be a little fickle. You know, they're not dedicated speech generating devices. So sometimes those adaptive tools that we use can be a little bit tricky and not as consistent as maybe a more dedicated speech generating device from a manufacturer that has manufactured this device solely for that purpose of communication. I hope I answered that question okay.
We have time for one more question.
This is a question for the respiratory therapist, and I just wondered, how do you determine whether one patient would be using the CPAP versus the BiPAP and other modes?
Typically with CPAP only has one pressure. So normally CPAP is mainly for a patient with obstructive sleep apnea, so their airway would collapse. So CPAP only has one pressure. So if you could imagine, when you inhale, you get one pressure. When you exhale, you have the same pressure. That's CPAP to AutoPAP to BiPAP. So there's 3 different machines. The AutoPAP will automatically adjust from low to high depending on what we set. So it actually works by flow and also acoustic. So as the airway starts to collapse, the pressure will increase and decrease. For somebody with motor neuron disease, I don't really recommend the CPAP or AutoPAP. The reason why is that the AutoPAP, if it gives more pressure, it's actually going to cause more central events or cause more hypopneas or shallow breathing. BiPAP machine has 2 pressures, an inspiratory and expiratory pressure. So normally, to determine the type of machine, we would do a CPAP titration study in a lab. What makes this different is, for patients that I qualify for with this spirometry study, the machine that insurance will cover, so again, it depends on insurance, just like Aaron mentioned, your spirometry value has to be a certain amount. The machine that I would order for you, insurance will cover it, and it's automatic. I could actually set a volume. So the difference between a CPAP and a BiPAP, it doesn't deliver a volume. The machines that we use delivers a volume. Because again, like I mentioned earlier in my speech, I want the patients to take a nice deep breath. And 2 of the machines for, say, ALS or motor neuron disease patients actually will deliver a volume. I hope I answered your question because I just confused myself there. No, but I hope I answered your question, but I'm available.
One more question from the internet.
We have another question from the internet, and the question actually started with a statement, and the statement was, "Thank you so very much for your presentations." The question is regarding the new Affordable Care Act. How will the changes that are rolling out with the new Affordable Care Act affect access to services that you're discussing in today's panel?
You know, that's a very good question, and some of those questions we don't really know. We have an administrative assistant who I'm actually going to refer that question to because he's been working really hard trying to figure that out. In some ways, it's going to be better for us. Some of the reimbursement is a little bit better. But without taking any of his thunder, I want to introduce you to our administrative assistant. His name is John Perez, to handle the rest of that.
So with the Affordable Care Act, what is considered covered California for the state, within the state of California, obviously, there's not going to be a lot of, there's going to be a lot of changes as it rolls out and as it gets more involved with people enrolling and all that. But when it comes to therapy service or multidisciplinary services, actually, there's going to be some advances to the point where the 3 companies that cover the Central California, the ones that carry the contract for it, they're actually going to be, have the services available for you. Now, as far as, if you're let's say you live in a different county, or the limitations will be based off where you live, really. Every county is going to have different, different restrictions and different limitations to what services are available. But, through the research that I've done and through the reading that I've done in the last, ever since everything started rolling out, the services will still be available to you. You'll still be referred from a physician, and, everything will just be kind of, there might be prior authorizations or something like that, but it shouldn't have too much of an effect where it's going to, cut off the, the service of a certain clinician for you. Hope that answers the question.
And also, just like any policy, every insurance policy has a different policy regarding durable medical equipment, which is the things that we would be ordering: blockers, wheelchairs, respiratory equipment, speech equipment. So, depending on that, we're not completely aware yet of how the durable medical equipment is going to be covered. That's very similar with every policy, every different insurance policy. They all have a different statement regarding that.
If you, the last part of what Erin was talking about is, if you have any questions about something being covered, there's websites specifically for like Medicare, Medicare.gov. You can go in and look up the equipment that you're looking for, and it will tell you which providers you need to go through. We do that. We have an assistant here whose name is Tiffany, who tracks all of that. So she makes our jobs really a lot easier because we say this is what we need, and she kind of goes out and finds out which company we need to go through, or looking at your benefits to help you understand this is how you can go that route. So as far as the services and the treatments go, I think getting in to see one of us is going to be pretty much the same as it's always been, with maybe a little bit of differences. I think the bigger unknown would be how are we going to have access to a lot of the interventions that we just talked to you about, and we just don't know. We would hope it's not that much different, but we'll have to see.
Well, thank you. This concludes the first session. I want to thank the panel up here. Clearly, you have demonstrated what an amazing team Dr. Rosenfeld has here at UCSF Fresno. So thank you very much. So we're going to take about a 20 to 25 minute break. I think if we can get everybody back into the room here at around 4:25, because our researchers are going to start coming in, and we're going to start promptly at 4:30. There's still refreshments in the room next door, so feel free to go and have some refreshments, visit with the vendors, and there's also some of the equipment up here if you want to come by and take a look at the equipment, and our panel will be around to answer more questions. Thank you.
And for those of you who are watching on the internet, please stay tuned. We are going to play some short films and interviews to entertain you during this break, and we'll be back online at 4:45.
Hi everyone, Fred Fisher, President and CEO of the ALS Association Golden West Chapter, here to say thank you so much for everything you made possible in 2013. Because of your support, we were able to serve more people with ALS, offer more support groups, and fund more research. And 2014 looks to be another banner year ahead, with more growth and expansion on tap.
We would not have a certified center at UCSF without Diane.
There's tremendous hope now that the use of the iPS cells that Shinya discovered will be leveraged to understand why ALS occurs by studying patients with ALS, and to find new drugs that might reverse or stop some of the disease processes that go on in ALS patients.
Get the 414 on ALS.
Get the 414 on ALS.
Get the 414 on ALS.
July 4th, a very significant day in baseball history. This was the day where Lou Gehrig, 74 years ago, gave his famous speech in Yankee Stadium. As Lou Gehrig was approaching, sadly, the final stages of ALS, well, it's the disease that bears his name.
Help the ALS Association to strike out Lou Gehrig's disease. Sign up today at nationalride-to-defeat-ALS.org.
As you know, one of our own crew members was diagnosed with ALS last year. So it's very important and heartfelt cause for our cast and crew to come out each year and try to support the Golden West Chapter as much as we can.
People think the cure for ALS will be found in a laboratory, but in fact, the cure for ALS will be found in people who are participating in clinical trials, and 2014 will be a banner year. It'll be an extraordinary opportunity for those who participate in our ALS clinic program and our community-based care services program to be part of the search for a cure. And with your help, I know we'll get there, because it's only together that we can defeat ALS.
Thank you.
My name is Harry Andronis. I was diagnosed May 19th, 2008. It actually started out with back problems. I thought it was age. I noticed my hands were getting weak. The doctor there told me that it was actually ALS. It was just sort of stunned silence for a short bit, and then joked about it. I find humor in almost everything. Bucking up, you know, it's like I said, I should be more freaked out about it, I think, but I'm not. And I'm not sure what that's about. So the clinic that they run over at Cedars-Sinai, there's some warmth and fuzziness to it, considering the general outcome of this disease. Yeah, they're not so clinical. I wish I did not have this disease, and I wish that people would understand what a devastating disease this can be. I wish, at the very least, that all pals could at least have the support to get through this. Thank you, folks.
My name is Edith Aurora Hughes Gonzalez, and I was diagnosed with ALS on March 27th, 2008. I'm an attorney, and towards the end of my trial, I found that my briefcases and boxes were a lot heavier. It turned out to be Lou Gehrig's. I didn't know that it paralyzes you. I didn't know that you lose your voice. I didn't know that it stops you from breathing. And I wish that my husband doesn't suffer. Having this disease doesn't mean your life is over. I cried a little bit, and then got myself together, and I turned to my husband and I said, let's go have a steak. I want to have a steak before I can't talk and can't swallow. The disease doesn't have me, I have the disease.
My name is Irene Moreno. I was diagnosed December 8, 2005. I had no family member with me when I was diagnosed. I was by myself. When I told my boss, it was crazy. It was like, I was driving on the freeway and he was crying. He was like, no, don't cry. And it would take me another 3 months after the diagnosis to realize what my journey would be. I've learned to slow down and enjoy my life. I'm not willing to give up. I believe in research. I think there's an answer. I would love to write a check and sign it. And I need someone to be with me all day while my sister works. The chapters help me in a lot of ways in my day-to-day life. They're all there fighting for me. And that's what you need, you know? Thank you.
My name is Michael DeAries, and I was diagnosed in 2001. My pinky wouldn't extend up all the way. Most of the progression has been muscle mass loss in my arms, my chest, a lot of fatigue. ALS was the diagnosis. After 7 years, I feel great. I'm one of the fortunate ones. So there is hope. It's not always a clinical 2 to 5 years. I was able to watch my son grow up from the age of 2 until 9. Actually, what I want to do is get the record for the longest living patient with ALS. That's my goal.
Scott was originally diagnosed in August of 2002.
My first symptoms were twitches in my arms.
My first symptoms were twitches in my arms.
And telling really bad jokes.
Telling really bad jokes.
That part didn't go away.
That part didn't go away. I took off my shirt and my arms and chest were twitching. And the doctor looked at me and said, "That's ALS. That will kill you in 2 to 3 years." And I freaked out.
And then he backed off.
And then he backed off.
And that was a crazy day.
And that was a crazy day. I told my parents, and that was pretty...
That's the one phone call.
That was the one phone call
You don't want to be making.
you don't want to be making. One thing I realized,
I liked food a lot more
I liked food a lot more
than I thought I did.
than I thought I did. One day,
I'm gonna get back in there.
you're going to get back in there? What are you going to start with?
Or, I'm doing lamb chops.
Lamb chops? Okay. All right. ALS.
Or the trust fall.
It's like a trust fall.
Or fall backwards.
And you fall backwards. Somebody is there to catch you. There are just so many people that help.
I don't know why I'm not laughing.
I don't know why I'm not laughing.
I need help to breathe.
I need help to breathe.
My name is Cheryl Payne, and I was diagnosed on May 22nd, 2008. My first symptoms were on the left side with my hand. I was actually pregnant with my twin boys at the time. In January '08, I started noticing difficulty speaking. I enjoy reading to my boys, and it's now difficult. It's limited me in what I can do, but it hasn't destroyed my spirit. I wish I could still run. I have 3-year-old twin boys, and they love to run, and they'll come up, "Chase me, Mommy." I have a lot of life in me to live. I truly believe that each moment is a gift, and I don't intend to waste it. I wish they could know me before the illness, when I could run and dance. I wish for a cure for this disease. The disease has taught me to open myself and let others help.
Thank you.
What if one day you could no longer speak, walk, feed yourself, or breathe without support, yet you could still think and feel every emotion? That day has already come for thousands of people with ALS, or Lou Gehrig's disease, a deadly disease with no cure or effective treatment.
ALS has already destroyed my ability to do many things I love. But with your help, we can find treatments and a cure. Join in the fight against ALS.
And join in the fight for hope. Visit actionals.org.
With its iconic lines, powerful 5.0 supercharged V8 engine with methanol injection system, and its head-turning red chrome paint exterior, the ALS Awareness Mustang carries on the classic lineage of the Mustang brand.
You say to yourself, what's Mustang? The first thing that comes out of your mouth is the Bullet. But Steve McQueen, an iconic person himself, has made Mustang very, very famous with the San Francisco chase scene. And me as a child growing up and seeing it older, and even to this day when I see it, I still get excited about watching that car going through the landscape of San Francisco.
A result of the combined talents of Gary and Kristen Watson of Creations in Chrome, along with Melvin Betancourt, the ALS Awareness Mustang was expertly crafted to be the centerpiece of the Golden West chapter's Rev Up to Defeat ALS campaign and a symbol of one man's battle against the disease.
The reason why I wanted to customize this Mustang for ALS was because I have a close friend that's been stricken with the disease. And I was present with him when he was diagnosed by his doctor, and to witness that, it was crushing for me. And at that moment, I knew that I had to do something to raise awareness for ALS and to do something for Kerry Hall.
What inspires me about Kerry and the way he's handling his ALS is that he still goes to work every day. He has 2 young boys and a wife. They do everything together, and everyone in the chrome industry has kind of rallied around him and helped him.
With Kerry in mind, work began to develop a stock 2012 Ford Mustang into a one-of-a-kind classic.
Gary and I have kind of this dynamic that we just kind of constantly bounce off ideas. And then I drew up a picture, and he says, that's it, I love it, that's the vision. So we just went from the front to the back, to the interior, to every nut and bolt. Gary's kind of a perfectionist, which is kind of cool. I beat him up all the time, but we do have a good dynamic, good working relationship.
We actually got the car 5 months before SEMA, which is really kind of unheard of to get the car that early. Usually you have about 10 weeks to build the car. And we got to put a lot of attention to detail in the interior, under the hood, and obviously the stunning chrome paint on the outside.
It's at this point that legendary driver and member of the Motorsports Hall of Fame, Parnelli Jones, joined the team as the Rev Up campaign celebrity spokesperson.
Well, racing has taught me a great deal about life because, first of all, automobile racing is very dangerous. Back in the 60s and 70s, it was a lot more dangerous than it is today. Every time we lost a driver or something like that, it was like taking a piece of your body away from you. It makes you feel like you're giving something back to society. I mean, I've had a great life. I'm very comfortable. I feel the obligation to, do what I can for charity.
Well, one of the things I would love this Mustang, this beautiful red chrome Mustang, to make people more aware of the ALS disease. The Mustang's a great vehicle for it. It brings a lot of people to look at it, but at the same token, there's a story behind it, and it's a true, powerful story behind it.
On the track, the ALS Awareness Mustang is an awesome combination of speed and beauty. Yet the car's true power will never be judged by its lap times. Instead, it will be measured by the number of hearts it can touch and the minds it can reach in the race to save lives.
If you don't know anything about ALS, better known as Lou Gehrig's disease, know this: it attacks your body. Eventually, your body will stop working. Your legs, arms, your lungs, but your mind still works. You know what's coming, but you can't do anything about it. But with your support in funding global research, the ALS Association can help people with ALS do this.
Fans, for the past 2 weeks, you've been reading about a bad break I got. Yet today, I consider myself the luckiest man on the face of this earth. I may have had a tough break, but I have an awful lot to live for. Amyotrophic lateral sclerosis, also known as ALS or Lou Gehrig's disease, is a progressive, fatal disease that attacks nerve cells and pathways in the brain and spinal cord, causing the body's motor neurons to waste away. Tragically, there is no known cause and no known cure. When it strikes, it changes everything for the person with ALS, for family and loved ones, and for everyone whose lives are touched by the disease. Lou Gehrig said he felt like the luckiest man alive, not because of the tragedy life dealt him with ALS, but because his disease helped him see and appreciate what is most significant about life. There are many affected by ALS who would agree and who would commit to living their lives as fully as possible, even when facing the challenge of the disease.
My spirituality allows me to experience life in a much richer way. So everything around me takes on a brighter facade. I feel as if I am seeing reality in a much different way.
I recognize that I don't have a long time yet, but I'm going to take every day and try to find something that's good about that day, something that I'm grateful for. And it's wonderful. I mean, that's another thing I didn't do with my life before.
The ALS community, you and I, are the heart of hope for people living with the challenges of the disease. It is overwhelming to deal with ALS alone, and that is why the mission of the ALS Association is so important.
In terms of the ALS Association chapters, I could not do the work that I do without the chapter. The chapter gives breadth and depth to what we do in the clinical centers. The clinical centers are the jewel in the crown for the chapters because we provide the care that increases quality of life, increases length of life, and that's now been documented in a number of journals. This makes my life worthwhile.
The ALS support group, it's made us feel not alone. And with this disease, you kind of stick out in a crowd, you feel alone. And to gather with a group of people on a regular basis and be able to talk about the things that we all need to talk about and address the issues that we need to address has been just a lifesaver for Leo and I, and we are eternally grateful and will always be grateful to the support group for the support and love and friendship that it's given us.
I met a series of people who were suffering right in the middle of their lives. And I realized I was working with heroes every day, whether it was the patient who was the man trying to kind of soldier on, or a wife who was giving up everything to take care of her husband. You'll never look at your own life the same way again.
When you feel out of control and you just need to rail at the world, the association has opportunities to volunteer, but also the walks, organizing friends and family to be able to raise money that we knew then stayed within the ALS community. It didn't just kind of go into this big pool of money somewhere.
People often think they're throwing money at an organization. They don't know where it is going to go. I have a walker. I have a wheelchair thanks to the ALS.
It is our commitment to work relentlessly to create a world without ALS, to leave no stone unturned in our search for a cure. The future decade is about knowledge fueled by innovation, new technologies, and hope. Thanks to an amazing convergence of science and technology, we have the tools for the first time to unlock the mysteries of this heartbreaking disease.
I make my living during my day job, but I feed my soul through my work with people who have ALS.
Because of your generosity, our chapter now has the opportunity and capacity to fulfill our commitment to the ALS community. We have done much in the past 10 years, and we will do even more with your help. Help us eradicate ALS so that no one will ever endure or live with the threat of the disease. Help us change the world, one life at a time.
Oh, please, it's at 4:30. I'm here.
Oh, you want me to sit up there?
Yes.
Okay.
Yeah.
Whoops. In your way, sorry. Okay. You got it.
I thought you were just going to push her down, don't let her go.
Well, go backwards so that they don't do somersaults. So that they don't accidentally somersault.
Well, she's got braids.
I don't really want to test them out. Great. We'll talk all about it. Please see attendance.
Hello everyone, can we ask you to be seated because we'd like to get started. If you want to come, there's plenty of room up here in the front.
Got you running.
Thank you. All right, we have 2 more people coming in. Great. Great, thank you. Okay. 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 Yes, we're ready. Thank you, everyone, for rejoining us again at this time. This starts our second session, Research Updates. At this time, I'd like to introduce our President and CEO of the ALS Association Golden West Chapter, Mr. Fred Fisher.
Hi, I've been in this building for 2 straight days with some of the best researchers in the world, and that's my first applause. It came at 4:30 in the afternoon on the last day, so I'm glad I hung out for that. Thank you for giving so much of your day. I know this is a long day for you, and you didn't actually come to hear from me. But by way of introducing you to what's coming next, because we really do have the privilege of not just having some of California's top ALS researchers here in Fresno for the past couple of days and here in the room with you. That's some of the world's top ALS researchers. The Golden West chapter, for those of you who don't know, is everything that's in red in front of you, including the state of Hawaii. And an important part of our mission is advancing global research, which happens through the ALS Association's Treat ALS program, which you're going to be hearing more about shortly. But to start off the afternoon, I want to give you all a pop quiz. I know you didn't come prepared, which is why it's a pop quiz. And the question is, where will a cure for ALS be found? Anybody? Right here. You know, that's only the second time in the year and a half that I have been giving this quiz that someone has gotten the right answer. Most people think that ALS research, that the cure for ALS is going to be found in a laboratory. And not to diminish the importance of laboratories, but I'm going to help you understand the Golden West chapter's view and the ALS Association's program and how it's going to help us find an effective treatment and cure. And it starts, as you said, with the people who have ALS. It's your voice. It's your family members. It's your friends. It's you who have a story to tell. It's you who engage in a support system. It's you who participate and join the chapter and gain access to not just support, but also to valuable information about how you can make a difference in the fight against ALS. And one of the big ways that you've done that is through advocacy. You've told your stories to the members of the California legislature. You've told your stories to the members of Congress. And when you do that, that creates both government and private funding for ALS research. The biggest source of funding for ALS research comes through the combined efforts that you create. It's your story. Congress cares about the plight of people with ALS. They allocate millions of dollars a year into ALS research. You bring us into your families, your friends, the places where you work, and they donate money for ALS research. That money goes into the labs that you're going to hear from today. Those labs, they're pursuing ideas. They're pursuing concepts. They're brilliant. And sometimes those ideas turn into ideas about a treatment. Where do those treatments go to be tested? They go to ALS clinics. They go right here. And all across California, all across the country. Those ideas actually get proven in people with ALS. Treatments aren't treatments until they actually work. The only way they know that they work is by doing clinical trials, where clinical trials happen in clinics with you. And so far, we know that there isn't a lot that works to slow down the progression of the disease. And the most effective thing to slow down the progression of ALS is getting great care, which means the people with ALS and their families participate in our community-based care services, and they go back to Congress, they go back to their friends, and they say, we don't have a cure yet, we need more money. The money goes into the labs, more ideas are pursued, those turn into clinical trials. So it's not a static process. What you're looking at here is a system. It's a multidisciplinary system supporting the search for treatments and a cure, and it cannot happen without you. It cannot happen without your voice. It cannot happen without the clinics. It cannot happen without the labs. It cannot happen without an organization that embraces you, that supports you, that drives this system. So as we move into this session about research, I want you to have an understanding and be able to picture in your minds where the research you're hearing about fits along this cycle. Because whether it's the care you're getting at the clinic or the work that's going on in the lab, in the end, it's all part of a research system. And you are the key element of that, which is why we're so grateful that you're here. With that, it's my pleasure to introduce you to the chief scientist for the ALS Association, who has flown here from London to be with us here yesterday and today, and she's flying back to London from here. So please give her a warm welcome, Dr. Lucy Bloom.
Did you put the educational one on? All right. It's not that one. Oh, thank you. I didn't want to give you the scientific version, so. Good, right? Thank you very much. Well, it certainly is a real pleasure to be here today, and to echo Fred's comments, it's certainly been an exciting 2 days together with clinicians and scientists, and talking about the challenges and opportunities to find treatments for ALS. And so what I hope to do in the next 15 minutes or so is give you a little bit of an overview of what we do at the ALS Association in our research program. And this is a schematic I like to show. It's very much what the industry says is their drug discovery pipeline, with initial ideas that go all the way through various stages of developments to get into the clinic as a testing, experimental test in clinical trials, and then to make sure that we can help improve living with ALS and hopefully also find a meaningful cure. So our programs really run from being very much basic research in the lab all the way through to translational efforts to make sure that we get ideas from bench to bedside. And we spoke a lot today in our scientific symposium about the opportunities using novel technologies, and one great partnership was with scientists and a company, us Pharmaceuticals, to help drive something into clinical trials. I'll talk a little bit about the drug discovery process in a moment. Just to give you a bird's eye view of our program, we have currently a commitment of about 20 million in projects worldwide. We've divided these projects into very distinct strategic areas. I'm going to talk a little bit about genetics. Understanding the disease is critical, and I'll tell you why that is. We have projects in clinical research that includes day-to-day living with disease, improving the living with disease, as well as clinical trials to try new ideas for treatments. Biomarkers, I'll explain to you what they are. Therapy development, those are attempts to work with academic and industry partners to develop new treatments for ALS. And then we'll hear a lot today about stem cells from Dr. Svensson. But we certainly also do not do this alone. Our partnerships are through networks of scientists and also networks of funding agencies. And at the NIH, we work closely with the National Institute of Neurological Disorders and Stroke as a partner for funding in many of the projects and often in many of the workshops. We work with the Packard Center for ALS Research. They're based at Johns Hopkins, and we have some very fruitful partners. The Therapy Alliance, based in Boston, are a funding organization. In the UK, we work with the NMDA Association to partner on funding, and in the US with the MDA Association, we are currently co-sponsoring a clinical trial, and more recently, a partnership with MGH directly. I think pivotal to the success in building research programs are the young scientists and clinicians that we bring into the field, who will be the preeminent scientists of the future. And so we're very proud of our Milton Safinovic postdoctoral fellowship program, funding the young scientists to do much of the studies that happen in the laboratories globally. And this is just a representation. We funded over 35 scientists in the last several years with these kind of programs. So you might have heard from Dr. Rosenfeld this morning, but I thought to put it into context to very briefly describe the kinds of things we are funding. It's very good to be able to visualize the complexity of the disease, and this might also help when you learn more about the stem cell approaches. That ALS is a disease in which the upper and the lower motor neurons are dying, and so the connections are very, very long distance, very complex, where these nerve cells with very small cell body and very long axon connect the brain, the spinal cord, and they then have to activate and stimulate the muscle for contraction. And it's this pathway and these complex pathways that are affected in this disease. For many years, and in fact the time that I entered into the lab, in Don's lab in 1993, we had a very motor neuron-centric view, and these are the motor neurons. They have very large cell body, long axons. This is in a healthy individual. This is an ALS. And in fact, my first project with Don, we're looking at the components of these cells, the neurofilaments. But much has changed over the last decade, and certainly we recognize that these cells, the motor neurons, which are important for the connections that we describe and for connecting to the muscle, are highly dependent on the supporter cell. And in fact, we always simplify things, but this in fact is a motor neuron. It happens to be a motor neuron from a rat with its single cell body, but it has many projections, not only that one single projection, the axon, but all these dendrites that have to make exquisite connections. And together with that, the astrocyte is in close connection with the neuron, receiving support and having a very strong trophic relationship between the two. And here, the black area that you don't actually see is the muscle. And although we look at the one single projection at the point that it connects with the muscle, it also has a very complex network. So all I'm trying to say with when we try to simplify the disease process and think about it visually, it's actually a very complex interconnection of different cells that are all involved. But because of that, we've now been able to get many clues and better understanding, and these are all areas we support funding for and think about. So when we think about what causes ALS, that is also quite challenging. We know that certainly genetics plays a big role, both in the cases where it's inherited, in 5 to 10% of the cases, and also very likely in a lot of the 90% of sporadic cases, genes play a big role. Aging is very much involved, as you recognize it's certainly a disease not in childhood, but in later 50 to 60 and onwards, and certainly environmental exposures are involved in the disease and certainly affect the age of onset, etc. So it's a complex interaction, and again, all of these areas we have programs and projects. But what is very exciting to point out, that although this is certainly a challenging disease area to focus on, the first discovery of the genetic cause of ALS came in 1993. It took significant time, 10 years later, to really begin to find many, many more genes. But it's very obvious from the slide to show you that the field has exploded and our understanding of the disease has certainly expanded, and the number of genes linked to the disease has been phenomenal. I highlight here, these are the familial cases of ALS, those that track through families, and there was at the time in 1993 we understood this part and this connection, and now we have much, much bigger part of that pie, and today we'll hear more about the C9 mutations. But you might say, well, what does it mean if we find all these genes? And what does it mean for those that have no family connections? Well, the genetics has made it really a tool for scientists to be able to begin to tease out the complexity of the disease. And part of this, a big part of it, is our ability to model systems in a dish. And we've gone from developing systems, cells in a dish, very simple yeast. We learned this weekend of some very exciting data, just taking very simple organisms, flies, worms, rats and mice. These models are what we invest in to really start teasing out and start understanding what's going on in the disease, and then using these same tools to test therapy ideas. And you'll hear a lot more about that when we talk about stem cells and what we've been able to do. So very simply put, because really all of it is about finding treatments and therapies and a cure, to do that, there's very systematic things we have to generate. And first of all, we have to have a target. So this is sort of called the translational drug discovery process. We have to have something that we are going to intervene and change to get an outcome in a person. And once we have a target, for example, if we're developing small molecules like an aspirin or something you can take once, twice, or 3 times a day, we then can go through to chemistries to develop this new drug. We will hear about other approaches that are very novel and very important as well that might circumvent the need for drugs, but in combination might be very valuable in treatment approaches. This then gets tested in model systems, be they cells and animals. Finally, obviously the most important test is to go after safety tests into humans, and that's the experimental trials that you often hear about. The challenge for us is that drug discovery is incredibly expensive and the success is very, very low. And so what we as an organization and what we do as academic and industry partners, we really build partnerships to help move it along faster, to help entice the industry to become involved. And the ALS Association plays a very pivotal role amongst other non-profit organizations to incentivize and to help build those partnerships with academia and industry. And it's no surprise then where the science has become so fruitful, we've learned so much more and made such progress that the partnerships have also increased. And many, many industry partners are now thinking about ALS. Even the bigger pharmaceutical partners, Pfizer, BMS, GSK. Why that is partly because the science is right, and partly because the success in the big blockbuster diseases like Alzheimer's and Parkinson's has been very limited, all very challenging diseases. And so there's real value to work with even the rarer diseases that have very good systems in place to try and test opportunities. And some of those systems are the networks. pivotal to that is, as Fred alluded, is the people living with the disease. It's really, they are the enablers of studies, of experiments, of testing new drug ideas. And so what we also try and do through our funding and through our programs is to really bring the academic and the industry sector together. And we have 3 programs, the details of which are not so important, looking at ideas that came from the laboratory. This is from Oleg Butovsky at Harvard University. Had a great idea, has done some very nice preclinical studies, and is working with a company, Reagan, to bring it forward. Likewise, another approach being taken by an investigator at New York and Columbia, working on the musk receptor. Again, an approach to try and improve the connection with the motor neuron and the muscle, together with Genentech, and then a very pivotal program, and you'll hear more about the new mutations in a technology that has started to prove particularly interesting for ALS. But together with helping with funding support for these partnerships, it's very important to build up the networks where these clinical trials, these experimental studies with patients in the clinic can be done. And for this reason, we support the Treat ALS Clinical Trials Network. It was an organization of clinicians and trial sites that started in the northeast of the country, and this just illustrates how it's now throughout the country. There are centers that have expertise and common approaches to doing clinical trials, so that when we have a clinical trial, you can enroll wherever you are in your local geography, and the centers can bring together the data from the trial. And in fact, through building this infrastructure, the number of trials and the opportunities have escalated through increased funding from the association to help make that work. We have many different trials going on. Most of them are actually smaller phase 2 trials. I'm happy in the question session to address any of them. We do know it's sometimes been frustrating because many trials have failed, but we do encourage that if you are able to engage in clinical trials. They are experiments, they are an opportunity to test an idea, but being involved in trials gives an enormous opportunity and the potential for eventually finding important therapies for ALS. One of the areas, and it's a very complex area to describe in very short time, is the need for biomarkers. And a biomarker is a signature that something is working. For treatments to lower blood pressure, very easy, you can just measure blood pressure. There are other approaches where you just take a blood sample and you can test that whatever drug you took has changed. That's the kind of thing we need to be sure when we take a treatment, it has worked. We also know that the diagnosis for the disease, although well done in an ALS center that is specialized in the area, still takes time because you often have to eliminate other potential confounding symptoms. And so it would improve diagnosis. That is critically important for us to treat the disease early. It will help us to understand better how the disease varies between one patient and another, because we do know that there is very different onsets, progressions, manifestations of the disease. We also know that it will improve our clinical trials. And importantly, we will also need to find ways to know if a drug has really gone to the area in the brain or the spinal cord that we need it to go and has affected the approach that we need to take. And so we have different approaches to doing this. We are developing systems to be able to measure with a simpler system than before activity of the muscle. This is EIM, and I'm going to just move through it quickly. There are also imaging technologies in which we can look at spinal cord and brain and see if there are changes over time. And we are also developing methods to look in real time at changes in the brain, and we call this PET imaging. And this is one example where we've taken, I mentioned that there are astrocytes that are support cells for the neuron. They are these cells that are very important to help provide appropriate nutrients. And some studies have shown that when those cells are compromised, they are no longer able to regulate glutamate. They have a special receptor called EAT2 that regulates glutamate, And when this goes awry, we have what is called excitotoxicity. It's not been very easy to measure this change in a real time in patients. And some of you might have been aware of a trial called ceftriaxone, where we were trying to change this balance of the ability to take up glutamate around the neurons. And unfortunately, we couldn't really determine in patients, it didn't work effectively, but we couldn't see whether in fact it was because we weren't able to activate the system. We are now developing an imaging system that we can label and attach a form of measurement so that we can actually in real time in patients measure the change of this particular phenomenon over time. So when we find ways to treat this approach, we can actually say it has or hasn't worked because we haven't changed the dynamics. So with that, I wanted to end and to really say that I think this is an incredibly promising time for ALS research, for ALS clinical studies. And it's the importance of your participation in these trials for biomarkers where you can be involved in providing samples, be it blood samples, CSF samples. These kinds of things are pivotal for us to help move the field forward. And with that, I'm going to move towards the next speaker in the panel, who will give you a real sense of what stem cells and approaches like that can do for ALS. And without further ado, it's my pleasure to introduce Dr. Klaus Svensson, who has for the last 13 years committed his time and energies and his lab talents to devising means to get stem cells into therapy. So we're very excited to hear from him.
Okay, thanks very much, everybody. Thanks, Lucy, for the great overview. So we're going to run through, I'll talk a little bit about stem cells and ALS. This is a topic that's obviously much excitement. Really based around, this is my biology 101. We're all made up of cells. The amazing thing is that all these cells actually stick together. So our body's made up of over 3 or 4 billion cells, maybe more, depends on who's counting. So we know that the body's made up of cells, and inside the cell, a lot of things go on in normal health, but in aging and in ALS, there are changes that happen in those cells that cause them to die. As Lucy just mentioned, of course, we know about the motor neurons in ALS dying, but there are also support cells, cells around those motor neurons that die. And I think this has been very interesting for everybody to realize, because the bottom line of what I'm going to tell you about stem cell therapy for ALS is that you might not need to replace that long motor neuron that dies. You may be able to use stem cells to just provide more support cells which will prevent those motor neurons from continually degenerating. And that's kind of the overall theme. And really, more generally, the ability to make stem cells means we can use stem cells more like a pill for patients with various diseases rather than taking a drug. So that's kind of the idea. It spawned this area of regenerative medicine, very new field. So now we're going to use stem cells to either repair damaged circuits or maybe help support them. Or you might be able to get your own cells to regenerate within the spinal cord and the brain. This is much more challenging. I think the main use of stem cells right now is going to be to provide support cells, and that's what I'll mention today. This is a huge market. There's a lot of interest in regenerative medicine in general and stem cell therapies. This is my hometown for 10 years. I'm not actually from Wisconsin, believe it or not. From a little bit further east in that little island called Great Britain. But I did move to Wisconsin in 2000, and a colleague there, Jamie Thompson, some of you may know, made the front cover of Time magazine because he discovered embryonic stem cells. And embryonic stem cells are the most powerful cells you can imagine. They're isolated from the embryo, the developing embryo, and there's a little picture of them down here. This colony here has about 200,000 individual embryonic stem cells. And these embryonic stem cells, of course, come from the fertilized egg. This is the blastocyst. This is when you're 8 days old. This is what you look like. You're the size of a pinhead. This is blown up. And these cells in here, this inner cell mass, we call them, are the cells that are going to make the whole human being and we take them out and put them in the dish, this is a petri dish here, we can grow these cells forever. They're immortal. Those cells can divide, make as many as we want. And then if we give them the right signals, we can make them into any tissue of the human body. Any of those 240 cells types you have in your body. Hair cells, we can make blood, we can make muscle, we can make bone. And of course we can make brain tissue, which is what's interesting for ALS patients. I want to show you these videos because of time. Now, the problem is politics in the US. You have to destroy embryos to make these cells, these powerful embryonic stem cells. President Bush wasn't too happy. There was a new president recently called President Obama. And interestingly enough, this is actually the CEO of Cedars-Sinai, where I work, Tom Presolak, who helped with the Obamacare Act, and the Healthcare Act has just gone through. So we've had a lot of interest in following the Healthcare Act through, a lot of interactions through Cedars-Sinai. But one of the things that President Obama did is he reversed some of the rules on embryonic stem cells when he came in 2009. And it was a big deal. He signed into effect new rules that meant we could now support embryonic stem cell work with federal funding. So this was fantastic. For those of you a little more astute, this is me. and for those of you interested in stem cell regeneration, I am going bold at the back. So I saw this picture and I was horrified. But we were very excited to all go down and see this come into effect. But no sooner had he signed this, there was an injunction filed, we were blocked again. My lab is NIH funded, and about a year after this picture was taken, I had to shut down all my stem cells, put them in the freezer until the government decided what to do next, because they were being sued by people who didn't agree with it. So it's been a rocky ride for embryonic stem cells. But luckily, there's an alternative. This is really science fiction. 5 years ago is now available. What we can now do is take any one of you in this room, any patient, isolate an adult cell from the skin or from the blood, and we give it just 1 or 2 genes. We put some cocktail together of these cells. This is a critical one called COP4. And this cell then goes back in time to an embryonic state. And this embryonic stem cell state we call induced pluripotent stem cells, or IPS cells. And these induced pluripotent stem cells are almost identical to embryonic stem cells. So even though you can't be an embryo again, we can make embryonic stem cells from any tissue in your body. So this is very exciting because it means from those tissues we can make neurons. We can also make motor neurons that now carry whatever gave you ALS. That signal, the genetic at least part of the signal, will be in those motor neurons. Now if you're exposed to something in the environment, we can add whatever's in the environment to that cocktail and try and understand more about what causes ALS. And this has been very exciting for me when I started working these cells, like turning lead into gold. Those old cells that we've all got, we can send them screaming back to being an embryo state, which is amazing on its own. Then we can divide them and make motor neurons. So we can actually get, you'll hear a little bit more from John next, we can make populations of motor neurons from every patient with ALS if we have appropriate funding, and discover why your motor neurons are dying if we do the right experiments. So this is very exciting, and we can also develop drug trials based on your own motor neurons without giving the drugs to you. So this is very exciting work. You don't have to rely on me to say it's exciting. There's this place in Sweden where you get the Nobel Prize. The person who discovered embryonic IPS cells, Shinya Yamanaka, got the Nobel Prize 2 years ago, Japanese scientist. Completely out of the blue, it's one of the fastest Nobel Prizes ever awarded. Within 5 to 6 years of discovering this technology, Stockholm gave him the call. All right, so very exciting. Just 2 more slides. So we've utilized this technology already. There's a disease called spinal muscular atrophy. Spinal muscular atrophy is a little like ALS in children. It's caused by a known genetic deficit. The children are fine until 6 months, and then they become floppy, unfortunately, and they lose their motor neurons. They all degenerate. Within about a year and a half, they are no longer able to move or breathe. Spinal muscular atrophy. So we made IPS cells. We took cells from these children, made the IPS cells in the dish, and then pushed them to be motor neurons. And what we found is those motor neurons died in the dish just like they died in the children. So this was our first model of a disease where motor neurons die. And so it's very exciting for us because now we can replay that disease again and again and again in the dish and add different drugs, see if we can slow it down. So this is called disease modeling. We call it disease in a dish. Sounds funny, but people do that, we get used to it. And then very recently, Bob Baylor, my colleague, is sitting here as part of this meeting today. I just spun out of 4 hours of discussions about this topic with all the scientists, with John and Bob and others, and Jeff. Very recently, Bob took not spinal muscular atrophy patients, but patients with ALS with this new mutation that Lucy mentioned, the C9orf72 mutation, one of the most common mutations now in ALS. We made the cell lines together, the iPS cells, and we turned them into motor neurons. And I think John might pick up on this story in a minute, but those motor neurons had changes associated with what we think is part of the disease process. And now we have this brand new model of ALS we never had before. We just had a discussion about how we might be able to test drugs in this model to change these changes we see in these cells that will be very relevant for ALS patients. All right, so this is super exciting. And the last thing I'll talk about, because we can make stem cells now, because we can generate cell types from them, potentially from you, so you make your own cells, we can also maybe regenerate them and then put them back into your spinal cord or back into your brain. And this is where my lab's been focusing. Right now we have funding from CIRM, from the ALS Association, National Institutes of Health, to do a very exciting project which we spent all morning yesterday talking about, which is essentially to take these cells, transplant them back into the spinal cord of patients with ALS. But before we do that, we're going to engineer them to make a drug, an extra whammy. Putting the cells back in is a bit like sending the troops in to the spinal cord. They're going to make new cells that will support your dying cells in the spinal cord. By giving them this, making them produce this drug called GDNF, we're going to arm them with a weapon. GDNF is now going to be released, and it's going to provide extra support, we hope, for the dying motor neurons. So this combination approach is going ahead. It's a bit like a Trojan horse. We put the stem cells in the spinal cord, and then they rejuvenate the area, produce astrocytes, and then they release this growth factor called GDNF, which is going to slow down, we hope, the cell progression to death. So that's a very exciting trial. We've got the cell line now. We've actually manufactured a cell line. We have 1,200 vials now sitting in a manufacturing storage facility at minus 180 degrees. What we have to do is thaw those vials out and inject them into the patient. And we're just going through the extensive preclinical programs that you have to go through in animals to prove they're safe. And then we'll be filing what we call an investigational new drug, IND, to do a first-in-man clinical study. It'll be the first combined stem cell and gene therapy approach for ALS. We hope to be launching that early next year. But I will warn you that this is an experimental process. And the first thing is, we are a year away. We have to reach milestones along the way. And if we have any breakdown in the process, we have to have a delay. So it's hard to say. Nobody will say, well, when is this available? Until we get a little further on, we won't know. But we have the funding in place, and we're progressing, and our target is early next year to be into patients. This is a collaborative effort with many, many different people, and we're working with all our colleagues in California. A lot of discussions today have been about collaboration, and we want to make this available throughout California, this technology, and further. So what would you expect, my last comment, what to expect from stem cell trials? The problem with stem cells is they sound like they're going to cure you. If you think the stem cells are like going to cure, they are powerful. One has to set your expectations. So what we're doing in everybody with stem cells is they're not treatments yet. They're experimental approaches. We have theories about how they might work. But if you go into a stem cell trial, this is experimental. All right? They shouldn't cost you anything. Our trial will not cost you anything. If they're properly conducted trials, they'll have support and funding from ALSA, from NIH, and they'll be through the FDA. We're trying to understand if they work. They'll probably only affect the region in which you have to transplant. We're actually doing a very specific transplant in the spinal cord. In the lower spinal cord, it's only going to affect the legs with this spinal cord transplant approach. So don't expect to be cured all over your body if we're only putting them in the legs. And it's been very clearly told to you when you go, if you enter into the trial. But I think these small, well-controlled trials with stem cells are crucial. We can get some results from these trials we will rapidly move with positive results into wider trials, into more stem cell trials into different areas. So this is important. Please beware of snake oil and stem cells. This is because of all the potential and hope. People are drawn overseas, drawn to stem cell clinics. Not everybody's doing it quite the way we are. A lot of people are using this to get patients to go visit. This particular company, Medra, is run by a guy, George Ryder, who's on their website. They will cure anything with stem cells, and it always costs $40,000. No matter what your disease is, they run through every disease known to man here. In fact, they have changed their name. They were shut down, and they now re-emerged as Stem Cell of America. They used to be called Medra. The future is already here. I don't think so. StemCellofAmerica.com. It's still Dr. Rada, who's the head of it, but it's just he's using different names. They even have a video of a muscular dystrophy patient who was cured, and it actually mentions how MDA has failed. And the only common theme with a lot of these clinics is $40,000 treatment. So be careful. I would advise the last slide. If you're interested in learning more about stem cell treatments, there's a very good website. It's the issci.org. And go into this area here, and it'll tell you if you're considering a stem cell treatment, what to look out for, what clinics are real, and what aren't. So please be careful. But other than that, know that we are working hard in well-controlled and regulated trials, and the FDA in America oversees this. So if you're in a trial in America, you know that it's been through a rigorous process. You're not allowed to do anything without the FDA approving the trial. But also remember, these are experiments at the current time. So obviously, we're very excited. And I would like to stop there and thank you, and maybe take questions after John. And my job now is to introduce Dr. Ravitz, and John is one of those neurologists and people you just feel better when you look at him. He's also a fantastic neurologist, and very happy to be able to introduce him next to talk a bit more about C9 and some of the work he's doing down in San Diego. So thanks very much.
Hello, everybody. I have only one slide, so I'll show it now, but we'll get to it later. And I thought what I would talk about today is more kind of zoomed out and talk about my perspective on ALS, and talk about past, present, and future to kind of give you some perspective as to how far we've gone and how far we have to go. And then to talk about what our strategies are in terms of talking about drug development and drug trials. And then thirdly, to talk about how we actually try to get a drug out and what the processes are so that you can understand it. I started in clinical practice in 1986 in Seattle, and was there for about 25 years. And so I'm now getting to be one of the senior statesmen in the field, and I can say I can really look back and talk about past, present, and future. And so I just want to give you a little bit of my perspective on that. I call the dark ages of ALS about before 1993. So that the past, I would say, ended around the early 90s, early to mid 1990s. And so I can tell you a little bit about just disappoint you on what kinds of things were happening in the field in the 1970s and 80s for the most part. For the most part, patients would go to the neurologist, would be diagnosed with ALS. The diagnosis can be complicated, and so would involve a subspecialty referral. And then the neurologist typically would then give you the diagnosis, give you the prognosis, and then refer you back to your family doctor. A family doctor might see one patient with ALS in a career. A typical neurologist might see a patient, an ALS patient, maybe once a year, once every couple of years in the general neurology practice. And then, and so the standard was to just refer back to the primary care. There's no treatment. There's symptom management, and primary care will know how to help you as if they would have any experience with it. And at the time, the anger, the isolation, everything about it was horrible to think about. And that was the dark ages. That was kind of the standard of practice. And it wasn't, I don't think, any bad intentions on the neurologists. We didn't realize as a group what our responsibilities were. We didn't realize we were diagnosticians, lots of things in our tradition. So it was kind of a paradigm shift. And I think in part the paradigm shift came with the AIDS infection, with HIV infections, which started in the late 70s, early 80s, where all of a sudden there was a very vocal, aggressive patient population who wouldn't accept that kind of an approach and demanded better. And eventually, and of course, to me, that's one of the miracles of modern medicine is what's happened with HIV infection. We've gone from this mysterious fatal disease to something that's, for the most part now, an outpatient controllable disease. And a lot of that was political pressure, and a lot of it was amazing science and drug development, and everything about it is miraculous. And so that changed, I think, the neurologists thinking about the responsibilities of taking care of ALS patients, and what our duty was, and what our responsibilities are, what the possibilities were. And the ALS, I'm not sure the patient population became more aggressive, but at least everybody recognized that we needed to be more active. And so in 1993 was the identification of the SOD1 gene. And then also, what's less known about that year is that it was also the first big clinical trial of a drug called the ciliary neurotrophic factor. And for some reason, two companies, one in New York and one I think in Colorado, got the idea that giving nerve growth factor could nurture the motor nerves and might be, and what was the disease of motor nerves? Well, they looked it up, it was ALS, and all of a sudden there were two competing pharmaceutical companies trying to test out this drug. And we were without any method for how to test a drug. You know, if you look around and look at the other people with ALS, you'll see how variable it is. We didn't really have a clue as to how to measure that, to test a drug to see if it was going to work. And so all of a sudden, now we had pharmaceutical attention. We had to come up with methods, and we also had a gene. So all of a sudden, we're off to the races in a really modern, in the present era. So that I would say began then, and hopefully the future is beginning now or in the last couple of years with the changes that have gone on. So over that period of time, say mid-1993, mid-1990s to the mid-2000s, we learned how to test ALS and how to measure it. We still have lots to do, but I think one of the biggest advances in the field has actually, from my perspective, has been in our clinical trials methods, our way of sort of how do we test a drug to see if it's going to work. There's been lots of discussion, lots of evolution. There's going to be lots of changes still to come, but we've sort of, I don't think that's a limit for the most part now. We have lots of ways of measuring. And so then the beginning of the future, and I would say if 1993, the identification of the SOD1 gene was the beginning of sort of the modern era, the future begins in, say, 2006, when a remarkable discovery came out from two groups, one at University of Pennsylvania and one from Japan, where they identified this protein called TDP43. And all of a sudden, turns out almost all of ALS has got this signature, this protein that's depositing in the brain and the spinal cord. And all of a sudden we had something that was kind of unifying, bringing it together, and we started really being able to think more specifically about lots of new ideas about mechanisms. And then as we're at 2011, was the identification of the gene C9orf72, which then re-exploded the field, which was still kind of trying to recover and reckon with TDP43 from 2006. Now 2011, we're rocked again by this new discovery of this gene. Now the gene for C9 is approximately, say, 7% of 6-7% of sporadic patients. You know that ALS, we talk about being sporadic, which means it's out of the blue, or familial, which means it's in the family. And we identify that really on the basis of whether other generations have been affected. So the main test for whether we say something is familial or sporadic is basically by talking to the patients and learning about their families. Sometimes we have a lot of information about the family. Sometimes we really don't have much information about the family, but we have to make a decision whether we think it's sporadic or familial. So it turns out we miss a lot because we don't have rich family histories for many patients, and we can't properly classify them. And but about theoretically 90% of patients are sporadic and 10% are genetic. So a lot of people are worried that they're going to transmit it, and most of the time it's not really a big risk as far as we know. But if you test the 90% who are sporadic, about 7% of them will have this gene. So it is a genetic, turns out to be a genetic abnormality. And of the 10% who are familial, about 40% of them carry this gene mutation. So it's really the most common gene mutation that we deal with in ALS, and it will account overall, say, for about 9 or 10% of all patients. So that still leaves 90% where we don't really have something to fix on, but it's huge when looked at from history that we have now all of a sudden with one mechanism, we can potentially deal with 10% of the population, 10% of our problem. And anyway, so that's where things are headed. And then stem cells, as Clive had just mentioned, has come along, and it is also rocking the field with new approaches and new ideas. And then the genetics, and so we're really off to the races. And I think all of us there's a lot of work to do, but I have real optimism and real hope that we're going to make major progress. And I think ALS is going to be one of the major diseases. We've had an era of cancer, we've had an era of heart disease, and this is we're entering the era of neurologic diseases, and ALS is really one of the major emphases for everybody. So there's a huge recognition and appreciation. Okay, so that's past, present, and future. Now the second thing I want to talk about is when we talk about drugs, what are we trying to do? And I think I find in talking to patients, it can be a little bit confusing. When most people go to a doctor, the doctor gives them a pill. And so we give out a lot of pills, and those are what I think you have to see in perspective. Those are symptomatic treatments. You know, you have problems with saliva, problems with sleep, problems with secretions, whatever it is, we give out medications and to help to alleviate the symptoms. Those are symptomatic medicines. We're not dealing with the disease. So realize that a lot of the drugs that people receive are elective. You don't have to take them if they're not helping. And people don't always understand that it's really, if it makes you better, take it, and if it doesn't make you better, quit it. The second is what you could call is controlling therapy. So like a diabetic who has blood sugar problems, they go and they get on medications which, like insulin, don't get rid of the diabetes, but they will control the problem from the diabetes. So one of the approaches that we have with ALS is trying to control the disease, not cure it, but control it. So a lot of things like Rilutech, as an example, doesn't control it, but it's designed anyway, or its claim is that it's going to slow progression. So a lot of things we're trying to do with different trials is to just have an effect on the disease to try to slow it down and somehow get better control of it. And then there are curing diseases. So when you take an antibiotic for your infection, you cure it, you don't control it. Blood pressure you control but don't cure, and so on. So obviously we would like to have a magic pill that would get rid of it, but then realize if we could wave a magic wand, get this magic pill, and cure the disease, patients would not be any better. Okay, so that's a big thing for people to realize. We would stop it from getting worse, but with neurologic disease, there's nerve loss. We can try to stop it from progressing, but we're not going to make patients any better. We're just going to eradicate the underlying problem. So that would be wonderful. The next generation can bring back and restore what's being lost, but mostly what we're trying now is either to control it or to stop the progression. And so the third part of that I want to talk about is just the stages of how if you have a candidate drug, how do you test it? What's entailed? Because again, I think patients don't always understand how complicated the process is. So we talk about 4 phases, phase 1, phase 2, phase 3, and phase 4 in trying to get a drug approved. So phase 1 is when you have a drug you want to test out, and then you say you just want to know if you can get it in and get an idea of administration and safety and make sure there's no magic or no major problems with it. So lots of trials you'll read about if you look at look at different drug trials, you'll hear phase 1, and that's really just very preliminary, trying to get started with the drug. Phase 2 is then you're trying to decide whether or not the drug is safe. Now that's a debate in the field because ALS patients will take risks. So safety is a relative issue. If you have low back pain, you're not going to take much risk. If you have ALS, you will take risks. So safety can be a relatively defined a problem, but nonetheless we have to get an idea of what the safety of the drug is, so what we're up against. And then phase 3 is what we call efficacy. Does the drug work? So finally, after these steps, we're now ready to test whether it will work in ALS, and we have all these measurements, and generally what we're doing is we're looking, there's a progression over time, you're looking at the rate at which it's declining, and you're comparing people who take the drug to people who don't take the drug, or a placebo, and then trying to compare to see if it's having an impact, and we call that efficacy. And sometimes we can combine safety and efficacy, so there's shortcuts you can take, and obviously for ALS in particular, we're aggressive to try to cut as many steps as we can to put things together to move things along. And phase 4 is after it's approved, you've decided, and then it's sort of post-approval monitoring. So those are the kinds of strategies we have in trying to deal with the drug. Now, the slide that I have is going back to this issue of C9 is what I consider the 2 biggest excitements in the field right now. We just had a couple of days of updating and sharing information and sharing ideas. With stem cells is number 1, and you just heard about that. And then the second is the gene therapies. And so I'll just tell you what I'm particularly excited about having to do with this how we would go after C9orf72. So remember, just a pointer here. Okay, so here is, let's get oriented to my own slide here. So this is this is a cell. This could be a neuron. Okay, and then this is the nucleus of the neuron. So this is where the sort of the grand central station of the cell is. And this is where the DNA is. So this is where the mutation is. And it's kicking out what's called messenger RNA. So I won't get too complicated here, but it's kicking out things that we want to get rid of. Basically, that's the point. And here is our new drug, which is called antisense oligonucleotides. It's got a complicated name, but what it is it's got just a sequence, and it knows how to recognize C9orf72, which it wants to get rid of. It goes through the cell, finds those messages that we're trying to get rid of, and it sticks to them. It recognizes it because it's a letter code, and it will only find its comparable letter codes inside the cell, and then it recruits a system inside the cell which just is there for other reasons, and it basically gets rid of it. So all of a sudden we've taken our bad message, we've gotten rid of it, and this will sit there, these oligonucleotides will sit there and just keep reducing that, and all of a sudden we've gotten rid of the primary genetic abnormality, which we think is causing 10% of patients is causing their ALS. So, and it turns out these drugs have been 20 years in the making. So I won't get into all the complexity of what's going on in the strategies. These have been actually 25 years in maturation and getting these technologies ready, and now they're really ready for their technology or a drug looking for a disease, and this is one of their diseases, and they're really going at this big time. So I think we'll hear a lot about this in the next 5 years as we really bring this into the patients, and we think we can, if not curing it, at least we will have what I think has the possibility of being a major control of disease progression. So it's got us all very excited. It's not enough because it doesn't cover the 90% of patients who still need help, but it shows us that we have really clever ways of now trying to fight the disease and fighting back, and it's the beginning of a lot of exciting things. So I'm going to stop there, and we'll open up for your questions.
Do we have any questions? Thank you, Dr. Question.
With regards to the discovery of ALS, I was just wondering with what disease was the science or the research started? What prompted it? Like, how different is ALS against muscular dystrophy or any kind of Parkinson's disease? Neuromuscular?
I'm sorry, I'm not sure I understand the question. Why, for the antisense oligonucleotides?
What prompted with what disease was this ALS studies based on? Like, how did they, let's say this ALS had not been existed, nobody know much about it, but pretty much with other disease process of the neuromuscular, there's some similarities. So how are they able to come up?
How do we diagnose it? You mean how do we recognize, say, ALS from muscular dystrophy?
Right.
Okay. So the bottom line is patients have weakness. So there's many different causes of weakness. And one could be muscular dystrophy, one could be ALS, one could be stroke, there's all kinds of things. But that's, for the most part, not difficult for the neurologists, because that's how we spend our time learning, is how to recognize patterns of disease, patterns of weakness, symptom complexes, and then how to localize it within the nervous system and measure it and detect it. So without trying to get too complicated about diagnosis, for the most part, ALS is not a complicated diagnosis for a neurologist.
And maybe I would, from a scientific perspective, say it was discovered in I don't remember the exact date, now that it must be 1870s, by a Frenchman actually, and images showing you the neuron and images of the brain gave clues that it was that motor system that was dying. So essentially it's as any of us now are trying to work out, it is through understanding what we see in the brain, the changes in the brain and the cells that give us clues about what the disease is doing. So it's not a new disease by any means.
Yeah, I have a question regarding talking about some of the political issues with stem cell research, embryonic stem cells. And now I've noticed there's been a little bit of talk about, I'll say, the benzothiazoles, the Rilotech. Apparently that's the only drug that's been approved to help us with ALS. I'm newly diagnosed, so this is all pretty new to me. And it talks about, like, it's an anti-infective, anti-inflammatory, anti-tumor agent, neuroprotective agent. And so I'm wondering about the cannabinoids, and especially CBD, like cannabidiol. These kind of, is there anything going on regarding that? Because it also seems to have neuroprotective effects and so forth. I have a lot of other questions regarding other meds, but
So I think I'll kick it over to Clive to talk about the stem cell part, but I probably should have said the third big event in 1993 was actually release of Relutech, and that was the first drug that was approved. It's been, it depends on who you talk to, how enthusiastic the neurologists are about it. It's a drug that's been around now for 20 years. Its claim is to slow progression. Repeatedly, as it's re-examined, it probably does slow progression to just a little bit.
Yeah.
So we know it's not enough, and not everybody takes it. I personally feel kind of torn because I don't want patients to be too put out by feeling that they should have to take it. It's got side effects, it's expensive, and there's other things, and I don't think people should be guilty for deciding not to take it. At the same time, it's a drug that's been available, it's been around for 20 years, and so we understand it. There's a bunch of other approaches, antioxidants, anti-inflammatories, cannabinoids. They're all attempts to try to slow the disease progression. But there's really nothing great in any of those domains. They're just areas that we're looking for and looking at, trying to find drugs in those categories. Does that answer your question? So the things that we're trying, they represent our attempts to try to slow progression.
So I think the interesting thing with stem cells and drugs are usually putting extra stuff in to try and block bad events. Drugs are trying to protect neurons, etc. Stem cells tend to suck bad things out. So a lot of ALS may be due to build-up of toxins, build-up of bad things around the motor neuron. If you put a young cell back in, a rejuvenated cell, a cell that's very young, it's young itself. It tends to suck out some of the bad things from the environment. So it's kind of neutralizing some of the toxic things that grow up as you get older. I mean, there's some evidence that senescent cells in the brain get old and they release things that aren't very good. So if you put a young cell in, it can help a little bit rejuvenate that area. So there's kind of different ways of looking at drug therapy for ALS. One is detoxification, and the other is addition. And sometimes doing those together, you take out all the bad stuff. And finally, the cells themselves are like mini drug factories. They pump out growth factors, they release cytokines, they make drugs. We don't understand half of what they make. But we know that some of those are supported. So that's kind of the stem cell approach. But again, going back to John, what we're trying to do is preserve what you have. It's almost impossible at the moment to replace neurons. In the future, we may be able to put a new motor neuron in and reconnect it. But we keep working hard. If I came back in 100 years, we'll be saying, well, now we're going to transplant motor neurons.
We have a question from the internet, and the question is for Dr. Bruin. In looking at your slide that showed the pie chart of all the active studies for the ALS Association, which wedge of the pie chart do studies about environmental exposure fit in?
So again, as I say, when categorizing these things, it's not an exact science, and a lot of these areas overlap. We do have some supporting studies which are both genetic and environment, so they might fit in that pie. Environmental studies are incredibly difficult to do because they require large trials and studies. We have worked actively with the Department of Environmental Health Safety in EHS, and they have studies looking at those kind of things. We have a small study going on in Vermont to look at influences of environmental exposures in that particular location. So we don't have many studies in our portfolio looking at the environment, and our bias has been towards genetics, largely because they are easier studies to perform, because you can directly test things, whereas environmental exposures, there are so many different exposures, and you have to look very carefully at populations to test that. But there are certainly people that are working on that, and we've funded those kind of areas in the past.
Thank you, Dr. Bruin. I actually had another question. This one is for Dr. Svensson. Dr. Svensson, can you talk about the clinical trial opportunities that are on the horizon with stem cells in people with ALS? How, where, when will they be conducted?
So there are many different types of stem cells. There are some stem cells which are called bone marrow stem cells and mesenchymal stem cells. These are adult stem cells. And there are a few trials trying to take these adult stem cells and inject them into the blood circulation of patients. There are not too many going on in this country. And those cells are more like trying to modify the disease, slow down the progression again. But they're temporary. They last in the blood a little while, and then you have another shock to those cells. The types of cells that we're talking about invasively injected into the spinal cord to add cells, there's really only very few. There's a neural stem trial, which is at Emory, recently expanded to Michigan. Very low numbers of patients. They're encouraging local patients because there's a lot of visits backwards and forwards to the clinic. Those two are the FDA-approved trials at the moment in this country. Our trial is slated for February of next year, of 15. If all goes well, that's when we'll start treating patients. There is a company in Israel who's doing some transplants of cells into the spinal cord, and these again are these adult mesenchymal cells that are talking about coming to this country. It's not confirmed yet, but there may be a small trial there as well. So there's very small numbers of trials, unfortunately, that's the answer. But as we're learning, it's such a new area, iPS cells are just discovered. And as we're pioneering these first trials, you'll see, I think, an explosion of trials once we get through these first patients. And we really need to see what these cells will do in humans. There's only very little data yet, and we've never done it before. So we're right on the edge of this new horizon. And once we start understanding how they react when we put them in humans, the FDA will allow us to go faster. And the Emory trial has escalated up. They started in the lower spinal cord, then they went to phrenic and breathing, and now they're doing high numbers of cells. So once we get on that pathway, you'll see more trials emerging.
Okay, I think we have time for one more question.
Hi, I actually probably have about 3 questions, but I'm one person, so. My husband wants to know, how do you know what is good as far as, you hear about the different stem cells that they're doing, different clinical trials, like we've heard of brainstorm, and we're not sure, you just mentioned that it's in Israel, and so we want to know, how do you know what is like a legitimate trial? And should I ask all 3 of them, or do you want to answer each one individually?
I think we'll just stop and answer each one. We can have an opinion. I did give a website, ISSCR, where they do review all of the different trials that are going on out there. You'll probably find that it's called Brainstorm, the company. You'll find the trial online. Just very briefly, my advice.
Or Neuron, I think it's Neuron.
Well, the company's called Brainstorm in Israel. And then there's the treatment is called Neuron. Yeah, it's like a special type of mesenchymal cell. It's an adult stem cell therapy.
Right.
My advice is, and without knowing the details of all these trials, and it's very complicated, if you're paying money, to go on a trial where there's no evidence it works, you're in dangerous ground because you don't really know. And I understand how desperate everybody is. So really it's your choice. I mean, because there could be something to it, but my advice is really try and get into the trials where it's a controlled trial, they're trying to learn about the disease. So I feel like every patient, if they get involved, we should learn something from it to take the whole community forward. So if you do something and just pay a lot of money and you actually take money away from something that could be helping your support of your lifestyle to kind of waste it on a stem cell trial, that's not good.
Okay.
It's difficult for me to make that decision, and Lucy and John may want to chip in.
To be candid, it's going to be unrealistic to try to get into a stem cell trial as of 2014. But there are other trials, so there are other approaches, and the way to find out about those is there are websites which are basically monitor what's available and where they're available, and those websites. One is trials.gov, and then there's the ALSA website, and then the Muscular Dystrophy Association will have a website. And those are the three that are the most up to date. You just go to the websites, look for clinical trials, and then it will link you to where the different trials are.
I just want to make a comment, if I may, and certainly the work that Clive and others are doing are critical in the stem cell area. But I think sometimes there's a sense that the only hope and the only cure is going to come from stem cells. And I think that that's a misunderstanding. And we heard that the work that John is involved in, Dr. Rabbits, to develop other technologies. It's very important to be broad-minded and realize that all of these are experiments. All are very important to move the field forward, and each of them have a different opportunity. And just to comment about the brainstorm, certainly that trial is going to come to the US. It's probably going to be quite a small trial. It's also extremely experimental, so it's not as if you can't get into that trial, you feel that you're between living longer and not living longer. It's unlikely to be, at this early stage of these experimental trials, make a huge, big impact. It would take away if you would not be able to get it.
Okay. And actually you answered the question I wanted to ask, how do you get into the clinical trials?
So again, I would echo what Dr. Rabbit said, and certainly on our website, if you go to the research page, there's a link to the clinical trials, and we partner with NEALS, the network I mentioned about. There's a searchable database. In that database is exactly the trial that you might be interested in, the location, the people that are contacts. And if you find it difficult to navigate, one is you can contact the ALS Association, but we also support a clinical trials coordinator who will actually, by email or by phone call, explain to you, talk you through it, say why you might not be able to be involved, get information for you. So that's certainly a resource that you should make absolutely all advantage of, and contact and email to get more information.
Thank you very much.
I think we have 3 more questions from the internet, and then I think we're going to close out the session.
The first question is for Dr. Rabbits. You discussed that even if we were to stop disease progression, it would not restore the functions that we've lost. Could some of the treatments that are currently being developed for remyelinization for diseases like MS help?
So a couple things to say. One is that if we can stop progression, things could get better. So that doesn't mean things are not going to get better, but the goal of treatment is to stop worsening, not to restore functions. Functions do come back, so there's always that capacity with anything neurologic for recovery. So just to be clear about that. I think the strategies for MS is multiple sclerosis is a disease which is very different than ALS. They share the one word sclerosis, but they really have very little to do with each other, so don't get confused about it. In multiple sclerosis, for the most part, the nerve is losing its insulation, so it's not conducting electricity, and it can happen in multiple places in the brain and spinal cord. And if you lose the insulation, the nerve is still intact, so then it can remyelinate, so it can re-insulate and then start functioning again. So that's there's much greater capacity for remyelination than there is for regeneration. So I think the short answer to the question is the strategies for MS are not going to be the same as they are for ALS. But in ALS, there's always the hope and possibility of regaining function if we can stop it.
Thank you, Dr. Rabbits. The next question is for Dr. Bruin. Dr. Bruin, could you talk a little bit about the ALS registry? Is it currently in use now by researchers? How many people are participating?
So this is the national registry that is run by the CDC, and that was really driven by public policy efforts and patient efforts. And in terms of it is certainly up and running. It is receiving data, and our public policy department is very actively engaged with our chapters throughout the U.S. to help with enrollment. the population of the registry really relies heavily on people living with the disease, and so we've tried to, through public policy efforts, facilitate, and through chapters facilitate you participating in it. There are studies that are beginning to emerge from it. The CDC has supported a few studies which have enabled investigators to make contact with patients, engage them in clinical trials through the registry. It's an option if you want to be involved in these various studies. They are also heavily engaged with the pilot part of building the biorepository as part of it. In terms of numbers, one, I certainly don't have them on my fingertips as to how many have enrolled and registered. Those are data that will be emerging. I know that there will be publications coming from it, and certainly there will be more available information moving forward. But I strongly encourage that it's up to people with the disease. If they don't know about it, get to know about it through your chapters, and it's through your enrollment and participation and filling out the questionnaires that we'll get all the data in place.
And final question.
This question is for Dr. Svensson. Dr. Svensson, you said that this was the 4th year of the Research Summit. What lies ahead in this next year for the Research Network?
Well, so nice finishing the questions. As chair of the network, it's been extremely exciting to see it grow over the last 4 years, and all these discoveries that John mentioned recently. Being at the center here in California of the C9 org story and stem cells, it's been very productive. And I think this year we're already talking about organizing the next meeting, and I think today and yesterday is just unique in that we get industry partners in the room, we get patients at the end discussing what we just discussed, what's fresh in our mind. We get all the doctors and researchers discussing, and I think more of the same next year. I think my term was, my mother used to say, if it ain't broken, don't fix it. So we're going to do the same thing next year. We're already setting up the dates. It's probably going to be, we don't know where it is yet, we're still discussing, but there'll be another one next year with probably another patient to prevent afterwards. So our idea is to educate the public, let them know we're working hard. And I think we're already filled with excitement at the moment. I think we always say that we're at a pivotal point, but I think with ALS, the combination of genetics and stem cells has come together in such a powerful way that we really may be able to make some progress in the next year. So we're very excited, and we'll let you know we're all working as hard as we can back in the labs and in the hospitals.
Thank you for that. Thank you for the questions. Thank you to those of you tuning in on the internet. I don't have the global reach of this event, but if it's anything like past events, we have people tuning in from all over, and it's an extraordinary opportunity to have such terrific scientists with us here today. So please give them a warm round of applause. While we're thanking people, we're in this beautiful facility, in this wonderful city, and I want to thank Dr. Jeffrey Rosenfeld for hosting the 4th annual ALS Research Summit. And I want to thank his staff. We know that these events do not happen without a lot of very hard work by a lot of people behind the scenes. So to the staff of UCSF and to the staff of Golden West Chapter, thank you to everyone who made this event possible. Most importantly, thank you, those of you online, those of you here in the room. It is truly you who make these events possible. Your support of the Walk to Defeat ALS, your support of the Campaign for Care and a Cure, your support of your local clinic, your support of the ALS Association. It's your support that makes these things happen. And without your support, we will not be able to power the search for a cure. So we're here for you, you're here for us, and it's only together that we will find a cure for ALS. So thank you for coming, and onward. Sure.
Thank you for hosting
I have something for you. From Urban.
Take good care. Kids doing your therapy.
Down right now. Great job.
Sorry.
Yeah, I should have brought my coat in, because I have a feeling it's going to be cold walking to that garage.
So good to see you. Thanks for
Nice to
coming.
meet you.
Yes, thank you so much for coming all this way.
Oh,
I'll be seeing you up in San Francisco soon, huh? That's great.
Honey, Oma.
Next Friday. Sounds good. See you too. Thank you for coming, Judy. Thank you.